The World Society of Pediatric Ophthalmology and Strabismus was founded in 2008. We proudly assert that expertise resides all over the world. We have members from across the globe in our bureaus, a WSPOS Executive Bureau, a Scientific Bureau, an Ethics Bureau, a Global Consult Bureau, and a Connectivity Bureau. The WSPOS Executive Bureau is composed of representatives from 6 countries across the world, all well-known and respected leaders in the pediatric ophthalmology and strabismus discipline. Our exclusive goal is enhancing the lives of children with eye disorders and both adults and children with strabismus throughout the world. This can be achieved through the international exchange of ideas, collaborative research, and policy implementation at both regional and global levels. Our core philosophy is the certainty that we are all teachers and we are all learners. WSPOS offers learning opportunities through online and in-person events. These events include congresses, subspecialty days, and a very successful webinar series which began during lockdown, but which has continued to a 3rd series, including a collaborative webinar with the WGA. WSPOS has almost 4,000 global members involved in pediatric ophthalmology in 119 countries. And membership is, and always will be, free. This decision was made because at WSPOS, we want to share knowledge with everybody, no matter who or where they are. So we hope you'll come and join us and avail of free membership, our library of online educational videos, and significantly reduced article processing charges for Carger's Ophthalmic Research Journal.
The World Glaucoma Association is an independent organization that unites all national and regional glaucoma associations, reaching over 12,000 eye care providers in the world.
The WGA exists for the education and training of its members, as well as the advocacy for its members and our patients.
The ultimate goal of the World Glaucoma Association is to connect ophthalmologists from across the world to improve patient care. We provide a platform for education, networking, and exchange.
The World Glaucoma Association brings the glaucoma community together with the latest knowledge to improve glaucoma care around the world. Webinars, the World Glaucoma Congress, and the Journal of Glaucoma are just a few of its rich educational resources.
WGA organizes the best glaucoma meeting in the world, which is the World Glaucoma Congress. Education is provided through several modalities, including online courses, consensus reports, and 2 journals. Information to patients is also offered through a dedicated web page, as well as active participation in the World Glaucoma Week. WGA also provides a fellowship program.
The WGA Fellowship Program supports glaucoma training for African colleagues so that they can return to their communities empowered.
WGA Global Webinars offer a modern education tool, bringing to the screen some of the finest specialists in different glaucoma topics.
The activities of the World Glaucoma Association pose an opportunity for education and at the same time advance the discussions important for improving glaucoma diagnosis, monitoring, as well as treatment.
Through online learning, over 12,000 members of our affiliated glaucoma societies have been able to learn continually from anywhere, anytime. Educating ophthalmologists around the world is our key priority to remove or eliminate glaucoma-related disability worldwide.
Staying connected with the glaucoma community is a key priority for the WGA. We welcome you to visit worldglaucoma.org, subscribe to our newsletters, and follow us on social media.
ophthalmology. Our second speaker is Dr. Arif Khan from the UAE. He is a consultant in pediatric ophthalmology and strabismus and in ocular genetics at the Cleveland Clinic, Abu Dhabi, where he is responsible for the pediatric eye care service. Dr. Khan is also professor of ophthalmology at the Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University. I really do look forward to both these talks and then the discussion to follow. So if we could have the two talks, please.
Hello, everyone. Today I'll be talking about classification and epidemiology of childhood glaucoma. Before we begin that, let's talk about how we define childhood glaucoma. It's not as straightforward as adult glaucoma. So it's essentially any IOP-related damage to the eye. So raised intraocular pressure, optic nerve head changes in the form of optic nerve head cupping, as you can see on the right, or any cup to disc ratio asymmetry. Corneal changes in the form of raised corneal diameter or Harp's tree, as you can see on the picture here, increasing axial length or a myopic progression, or a reproducible glaucomatous visual field defect. Two or more of these changes can be defined as glaucoma. However, if just one of these changes is present, we call it a glaucoma suspect, and we do need to monitor these patients and look for any progression. So going on to the classification, the classification I'm going to discuss comes from the Childhood Glaucoma Research Network. This is a standardized classification that encompasses a wide variety of diagnoses, and it is very descriptive, and each of the categories is exclusive of each other that helps in making diagnosis and also reporting outcomes. So essentially, childhood glaucoma is divided into primary and secondary. Primary is further divided into primary congenital glaucoma and juvenile open-angle glaucoma, depending on the age of onset. The secondary is further divided into three categories, depending upon the associated conditions. If it's associated with any non-acquired or congenital anomalies that are present at birth, any acquired conditions, or following cataract surgery. The cataract surgery is a separate category, and we'll discuss why in a bit. I'll go over each of these categories briefly, one by one. So going on to primary congenital glaucoma, all the features of glaucoma that we just talked about, in addition to that, there are isolated angle anomalies. As you can see on the picture on the left here, on the gonioscopic appearance is essentially a featureless angle. You cannot make out the structures of the angle. You cannot make out the ciliary body band, and there is a high iris insertion. Compare it to the picture on the right, which is a normal infant eye, and it beautifully shows all the angle structures. So primary congenital glaucoma is the most common form of glaucoma in infancy, and depending on which part of the world you're in, it can have a variable incidence, highest being in communities which have a higher rate of consanguineous marriage. Going on to juvenile open-angle glaucoma. If there's a higher age of onset, we call it juvenile open-angle glaucoma. However, there is no ocular enlargement as compared to primary congenital glaucoma. As by the definition, you can see it's open angle. However, the angle can be anomalous with a high iris insertion or prominent iris processes. These patients usually present with very high intraocular pressures, and this glaucoma is relatively rare. Going on to the secondary glaucomas, first, we'll talk about the ones associated with non-acquired or congenital anomalies, or the anomalies that are present at birth. This is not an exhaustive list, but these are just the common conditions that can be associated with glaucoma. Glaucoma may not be present at the onset of diagnosis, but there is an increased predisposition to glaucoma, and therefore, once a diagnosis of these conditions is made, you need to monitor these children lifelong. The most common ones are Axenfeld-Rieger anomaly and Peters anomaly, where as many as 50% of patients can go on to develop glaucoma. As you can see in the patient depicted on the pictures above, there's a patient with Axenfeld-Rieger anomaly with posterior embryotoxin and angle anomalies. They did go on to develop glaucoma. Similarly, Peters anomaly, the pictures below, shows a corneal opacity with the keratolenticular adhesion. This patient does have glaucoma. There's no angle structures visible. The other common condition is aniridia, in which about 50 to 75% of the patients can go on to develop glaucoma. It's important to identify, as a prophylactic goniotomy can reduce the incidence of raised intraocular pressure and glaucoma. Going on to the systemic anomalies, it includes a wide array of syndromes, including chromosomal disorders, metabolic disorders, phacomatoses, and these all account for about 11% of all childhood glaucoma. A common one is port wine stain-related glaucoma, where you can see there's raised episcleral venous pressure as depicted by the blood in Schlem's canal that you can see on the gonioscopic appearance. It can be associated with Sturge-Weber syndrome, and these children can have choroidal hemangiomas as well, which makes the optic nerve head cupping assessment difficult and is important to take note. Going on to the acquired conditions, it also includes a wide array of conditions, commonly uveitis and trauma. Any blunt trauma to the eye, and if it causes angle recession, predisposes to glaucoma, and these children need lifelong follow-up for intraocular pressure monitoring. Steroid-induced glaucoma is also common in children, and they do have a higher response rate as compared to adults. Benign tumors, just as juvenile xanthogranuloma, as you can see in the picture here, and even ciliary body cysts can cause glaucoma with angle closure. Any surgery, intraocular surgery to the eye, can predispose to glaucoma as well and is important to note. Going on to the last category, that is the glaucoma associated with cataract surgery. It is a separate category because independent of what the cause of the cataract was, the cataract surgery in itself increases the risk of glaucoma. It is hypothesized that just the mere exposure of the trabecular meshwork to lens matter causes damage to the trabecular meshwork and raised intraocular pressure. It is indeed the most common cause of secondary glaucoma, and once the surgery is done, there is a lifelong risk of developing glaucoma. There is a higher incidence noted if the surgery was done at less than 4 weeks of age. The use of intraocular lens in cataract surgery and preventing glaucoma with its use is controversial. So to summarize, this is a nice flowchart that is available at the Childhood Glaucoma Research Network website, and it helps you categorize your patient in one of these categories. However, to be able to do that, it is important that you do a thorough clinical history, perform an exam, examine the whole child, not just the eyes, and do serial eye exams and an eye exam under anesthesia if necessary. Thank you.
Hello, my name is Arif Khan, and it's my pleasure to participate in this glaucoma webinar. I've been asked to speak about the genetics of childhood glaucoma. What do we know now? And I've decided to concentrate on primary congenital glaucoma and focus on 3 concepts. The first being that CYP1B1 is the major primary congenital glaucoma gene, but age of onset can vary. So CYP1B1 is from a gene family that metabolizes complex molecules. It's associated with recessive primary congenital glaucoma, but the prevalence varies greatly depending on what part of the world you're in. For example, in Saudi Arabia, over 90% of primary congenital glaucoma is from CYP1B1 mutations, whereas in the USA, it's less than 20% of primary congenital glaucoma. The associated phenotype is often a very severe neonatal form that doesn't respond well to angle surgery, but sometimes milder phenotypes occur. We sometimes see milder phenotypes even within families of patients with severe neonatal forms from CYP1B1 mutations. So here's a baby with this 2 copies of exactly the same CYP1B1 mutation, that is to say a homozygous CYP1B1 mutation who has a severe congenital phenotype. Another baby with the same homozygous mutation, but variable expressivity in that the right eye is more severely affected than the left eye. And here's a child with the same homozygous mutation again, but didn't have congenital glaucoma, at least not obviously. At about 1.5 years old, started to noted to have enlarged corneas and corneal haze and more of an infantile onset glaucoma. This family is very interesting. The father and the 2 children all have the same homozygous CYP1B1 mutation. The unaffected mother is a carrier for the mutation. The two children had severe neonatal congenital glaucoma, but the father never had childhood glaucoma. He developed juvenile glaucoma in his 20s. He never had any ocular enlargement. Just shows how there can be variable expressivity even within the same family of a child with severe CYP1B1 related primary congenital glaucoma. The next concept I'd like to share with you is also related to CYP1B1. It's the fact that CYP1B1 can also underlie anterior segment dysgenesis phenotypes. So this phenotype of partial aniridia, ectropion uvei, and central intrinsic corneal opacity is pathognomonic for CYP1B1 mutations. It doesn't require any further workup or any further investigations. Sometimes we see glaucoma from CYP1B1 mutations being associated with a primary iris abnormality as well, sort of resembling Axenfeld-Rieger spectrum. And sometimes congenital glaucoma from CYP1B1 mutation is in the setting of Peters anomaly. So we have all of these different anterior segment dysgenesis phenotypes, more than just trabecular dysgenesis, that are possible from CYP1B1 mutations. This child with congenital glaucoma has an intrinsic central keratopathy from CYP1B1 mutation. And take a look at this slit beam, the posterior aspect. You can see that there's a dimple there. This child actually has a posterior keratoconus, very characteristic for CYP1B1 related keratopathy when it occurs. The final point I'd like to share with you is related to another gene that's been associated with primary congenital glaucoma, LTBB2. And although it's been associated with primary congenital glaucoma, it's more commonly associated with a phenotype that can be mistaken as primary congenital glaucoma. LTBB2 is a gene from a family that acts in the extracellular matrix. Mutations in the gene have been associated with recessive primary congenital glaucoma, based primarily on two reports that occurred in 2009, a few consanguineous families. But since then, most have not found LTBB2 variants in their CYP1B1 negative primary congenital glaucoma cohorts. The reason is that, in fact, mutations in the gene are much more associated with a phenotype that can resemble primary congenital glaucoma. Primary megalocornea with zonular weakness and a secondary lens-related glaucoma. This can be mistaken as primary congenital glaucoma if the patient is phenotyped late at an end stage, or if early phenotyping is not done carefully. The fact that the knockout mouse model shows fragmented zonules and no trabecular meshwork abnormalities really confirms this clinical experience, at least that I have, of what the true, more common LTBB2 phenotype is. So you can see why this patient might be thought to have primary congenital glaucoma, but you can also see why this patient couldn't have primary congenital glaucoma. A baby couldn't have corneas of this size from increased intraocular pressure without some degree of Habe stria or corneal haze. This is the big clue that we're dealing with a primary megalocornea. This child experiences spikes of increased intraocular pressure because the zonules are weak and the lens comes forward and causes intermittent pupillary block. Patient like this, the lens has to come out. Angle surgery is really disastrous. We need to recognize these patients when we encounter them. It's much clearer when a patient comes in with the lens in the anterior chamber, like this 4-year-old. Everyone understands that the lens needs to come out. The more tricky situation is the situation I showed in the previous slide. This is a 4-year-old. Again, look at the size of these corneas. This is the LTBB2 phenotype. These children do very well when the lens are taken out and they're made aphakic. They don't get glaucoma in my experience once you do that. Very important for us, those of us who take care of glaucoma patients, to be aware of and recognize this phenotype. That brings me to the end of my presentation. Thank you very much for the opportunity to participate, and I look forward to the rest of this webinar.
Okay, so thank you very much. If I could ask Arif and Meghal to unmute and get their videos. Both fabulous talks. Thank you very much. And we've generated a lot of questions from the audience. So before we start that, Arif, I wanted to just discuss the CYP1B1 situation. My group wrote about CYP1B1 cytopathy. That's what we named it. And in fact, von Hippel, when he described his ulcer, described it in a child with ophthalmos. And so that what you described as posterior keratoconus, I wonder if it actually is a von Hippel ulcer, you know, in the olden methodology of naming things.
Yeah, I agree. I would consider it to be the same. Thanks for bringing that up. I just, in the time constraints, I didn't go into.
Yeah. No, of course. But your points are well taken. So the first question is yours. It says, Dr. Khan, do you recommend genetic analysis in these patients? When and how? And is there any test that clinicians may ask for? So a big question.
Yeah, sure. Well, when you say these patients, I suppose you're saying patients with congenital glaucoma or anterior segment dysgenesis. In general, although I'm a big advocate for genetic testing, you don't need genetic testing to manage these patients. You really can decide on the management from the phenotyping. However, you know, there are some phenotypes that you have to worry about being associated with maybe some extraocular features, such as classic aniridia, although that's typically not a congenital glaucoma. If you're suspecting you have a baby with a new classic aniridia, you have to worry that there might be a new deletion and the risk for Wagner syndrome. But in general, when we're dealing with childhood glaucoma, the phenotype is really king. We decide on how to manage these patients, not on the genetic testing results, but on the results of our clinical exam. And clinical exam is key. And I really want everyone to be aware of this last point that I made about the LTBV2 patients. We can recognize these patients without genetic testing. We just have to be careful in our phenotyping, get a good exam. Don't jump to surgery unless we have a good exam.
No, great points. And on that note, Meghal, when you you've done a dual fellowship. When you see a baby with glaucoma, and it's obvious, it's got ophthalmos, hazy cornea, what are the things that run through your mind before you think about genetic testing?
I would always examine the parents first, ask for any consanguinity. Those were the points I would look for. If there are any mild changes, like sometimes they would have iris hypoplasia or just a posterior embryotoxin which got unnoticed. So that would point to a different diagnosis altogether.
Okay, that's great point. So we're going to move on to the cataract, post-cataract surgery glaucoma. So it says many patients with cataract surgery post-congenital cataract have thick corneas. Do you measure hysteresis in these patients? And how do you calculate the IOP in these cases? So Meghal, we'll start with you and then we'll ask Arif his opinion as well.
It's just not possible to get hysteresis in these babies in clinic, so we don't do that. But it's important to kind of see the eye as a whole, not just the intraocular pressure, the changes in the corneal diameter, the axial length, the refractive error, and kind of put all of that together. If there are no other changes and just the IOP seems to be increased, then we would just observe them and definitely get a baseline corneal thickness measurement in clinic.
Arif, what's your advice?
Yeah, this is an excellent question. After cataract surgery, we know that corneas are thicker, and that's important information when interpreting the IOP, although there's no real mathematical formula way to do it. I'd like to say that increased intraocular pressure glaucoma after cataract surgery is both overdiagnosed and underdiagnosed. It's underdiagnosed in that we really have to be suspecting it. Every patient who's had infantile cataract surgery is a glaucoma suspect unless proven otherwise. And that's how we have to think about it. Otherwise, they can go for a long time and not get diagnosed until they come in with a really high pressure and really advanced cupping. It's overdiagnosed because sometimes they have thick corneas, inelastic corneas, and the pressure measures high, but it's not really high. And it's very important that we take in the corneal thickness into account. We don't have these nomograms that are available for adults in terms of interpreting these thick corneas. But as Meghal alluded to, we have to look at all of the parameters when we're dealing with childhood glaucoma put them all together. It all has to make sense. And one of those parameters is the corneal thickness. It's like a cookbook. It's not an exact science.
So on that note, Meghal, back to you. It says, there's a question about the age of onset of juvenile open-angle glaucoma. So we're going to move away from the infantile glaucoma to the juvenile open-angle glaucoma. What is your having given us all the definitions? What's the definition that you use?
I think after 3 years, anybody who's older than 3 years, that's when sort of the elasticity of the eye decreases. That's when they would not have any ocular enlargement or corneal enlargement, if I were to say. So that's when I would start thinking about juvenile open-angle glaucoma.
And but that's in the absence of other sort of developmental signs.
Yes.
Arif, unless you have anything to add to that, I wanted to ask you, there's a question about what's the cutoff for the CD ratio for definition of increased CD ratio in children? That's an interesting question, I think. And it also says then, do you offer brain imaging for children with increased CDR without other signs of glaucoma? And that, of course, is a whole new basket of issues.
Yeah, but in general, yeah, and it's hard to give a number. In general, babies don't have much cupping, but if you have a premature baby who had periventricular leukomalacia or microcephaly, you might have some cupping. That's a form of optic nerve hypoplasia. It's not a simple answer, but I'll say in general, in a healthy baby, there really shouldn't be much of a cup. It's almost nothing. And in older children, if they're highly myopic, they might have a bit of a cup. Whereas if they're hyperopic, you wouldn't expect much of it. So I would say refractive error and age comes into play. We really have to look at everything together. Children are developing, and actually the cup does increase a little bit in the first years of life. So we have to be cognizant of that. And if there's ever a suspicion, OCT has been very helpful, and following the patients also is very helpful. But I would say most of the time we see cupping and there's no sign of glaucoma, other sign of glaucoma, it's often physiological in children. We have to be careful about overdiagnosing cupping.
Yeah, so one of the things that I found really helpful is since with the advent of OCT is you can see if a disc is really big, and if you've got a really big disc, then you're going to get a big cup. So it doesn't necessarily always mean that if you've got a big cup that you've got glaucoma. And one of the other things that I found is asymmetry is more important to me than the actual number, if you like, of the CD ratio. Meghal, what's your opinion? I know you do a lot of the glaucoma suspect work with Dr. LD at Children's. What's your take on it?
I think other than the cupping, what we need to also look for is the other subtle signs of glaucoma, not just the cupping, any peripapillary atrophy, increase in the beta zone. We can get pictures, even if we cannot get OCT, and serially just monitoring those would help. Look for vessel changes. If there's any notching present, like soft signs of glaucomatous changes that are more important to me rather than just looking at the cup.
I'd also like to add that very often, in these borderline cases, follow-up is very important. And we shouldn't think that we can make the conclusion in one visit, and always totally be prepared to bring the child back and reevaluate.
So just to finish that question off, the question about imaging, I wouldn't image just on the basis of the appearance of the optic nerves. I'd look at the whole child and see if there were any other delayed milestones, if the parents felt that there was something else not quite right, and I'd get a neurology or a pediatric opinion before jumping to imaging if I genuinely thought that there was PVL or anything other that was neurological in origin. So there's another question for you, Arif. Dr. Khan, thank you for this brilliant presentation. I totally agree. In the case of variable expressivity, what is our guide since new presentations are expected? That's a great question.
Yeah, I mean, this is where research comes in. We used to think that CYP1B1 only caused primary congenital glaucoma, isolated trabecular dysgenesis, but now it's very clear it can cause iris abnormalities, corneal abnormalities. I would say that we want to do more genetic testing on more phenotypes, and not only certain genes, but as we do more whole exome sequencing and complete genome sequencing, hopefully we'll be able to figure out what the modifiers are, because the modifiers are very likely other variants in the genome. These gene mutations do not act in isolation. They act in the context of the rest of the genes in the body. And it's very likely that variations in other parts of the genome are what is contributing to this variable expressivity for the same mutation in two different people.
No, that's a great answer. Thank you. Meghal, any relationship with the timing of cataract extraction and development of glaucoma in congenital cataract?
Yes, absolutely. There have been multiple studies that have shown if the cataract surgery was done at less than 4 weeks of age in a neonate, then there's definitely an increased risk of glaucoma.
Yeah, I mean, that work came from our group in Great Ormond Street about 15 years ago, and then Mina Matazzi did a real world data, huge study confirming that information. Is that your experience as well, Arif?
Yes, definitely. And of course, as you're aware, but it's important to say, one of the reasons this terminology has changed to glaucoma after cataract surgery as opposed to aphakic glaucoma is because there are many different mechanisms. We're talking about it as it's one mechanism, but there certainly is a mechanism where we just remove the lens, something happens to the development of the angle, but residual lens fibers, sloppy surgery, vitreous substances coming into the AC, postoperative inflammation, there are many different pathophysiologies. So this is one of the reasons this renaming was important.
Okay, we've got about a minute left of discussion. This is a nice question. It says, in primary congenital glaucoma, it is common to have corneal edema preventing accurate IOP and fundus examination. How is it possible to make the diagnosis? So I think this is a great way to end. So Arif will give, we'll let Meghal give her answer, and then we'll finish up with you, if that's okay. Meghal?
I mean, again, it's not just the intraocular pressure, but the whole eye that we're looking at. So if there is corneal edema and you can see H3, you can see the fundus, you have got to lower down the intraocular pressure before you can do anything. And look, just adding on the drops will kind of temporize and help you do everything else before you can do a more definitive management.
Arif, final
I would say the questioner brings up an excellent point. There are some congenital corneal abnormalities where the cornea is abnormal and the pressure measure is high. So if you see a baby with a hazy cornea and high measured IOP and no evidence of extraocular enlargement, I would watch and wait. You really have to be sure that you're dealing with congenital glaucoma before you start operating on patients. It's a whole other topic. But CHED, congenital hereditary endothelial dystrophy, can present with a hazy cornea, high measured IOP, and be mistaken as glaucoma. So that's an excellent point brought up by the questioner. Again, we have to look at everything and not jump into it if we're not sure. Everyone is very excited that something has to be done, but if you're not sure, better to observe a little bit.
Yeah, and great advice. On that note, measure axial length. There was a question about that we didn't get to. Thank you, Meghal Gagrani. Thank you, Arif Khan. And that brings our session to an end. That was wonderful. Thank you very much for your participation.
Thank you so much. Thank you.
So I think
Good
Alicia,
morning, and first of all, I'd like to thank the organizers of
session 2. Sorry, Alana, I apologize. Alana.
Participate, and I'm going to talk about congenital glaucoma, the clinical manifestations and diagnosis. And congenital glaucoma Good morning, and first of all, I'd like to thank the organizers of this webinar to invite me to participate. And I'm going to talk about congenital glaucoma, the clinical manifestations and diagnosis. And congenital glaucoma is a rare and severe disease. The early diagnosis and treatment are crucial for a good visual prognosis, and we have to take into account two facts. First is that the clinical manifestations in children are different than in adults. They are related to characteristics of the eye in children, with a lack of scleral and corneal rigidity. So the clinical manifestations depend basically on the age. And the second is that the initial diagnosis and assessment of progression in children are very challenging because of the lack of collaboration. We try to obtain most information in the office, but a complete examination on the general anesthesia is usually needed, so we don't have to disclose it. The diagnosis of glaucoma is based in two or more of the following facts. First is a high IOP, confirmed.
Those started similar to the last session. After the second presentation, we'll move into a 10-minute discussion. So let's go first with Alicia's presentation.
A complete examination on the general anesthesia is usually needed, so we don't have to disclose it. Good morning, and first of all, I'd like to thank the organizers of this webinar to invite me to participate. And I'm going to talk about congenital glaucoma, the clinical manifestations and diagnosis. And congenital glaucoma is a rare and severe disease. The early diagnosis and treatment are crucial for a good visual prognosis, and we have to take into account two facts. First is that the clinical manifestations in children are different than in adults. They are related to characteristics of the eye in children, with a lack of scleral and corneal rigidity. So the clinical manifestations depend basically on the age. And the second is that the initial diagnosis and assessment of progression in children are very challenging because of the lack of collaboration. We try to obtain most information in the office, but a complete examination on the general anesthesia is usually needed, so we don't have to disclose it. The diagnosis of glaucoma is based in two or more of the following facts. First is a high IOP, confirmed, optic disc damage, visual field defect, and up to here is the same as in adults. But when the child is younger than 3 to 4 years, and the eye is still vulnerable, we can find also corneal signs of enlargement or habstria, and increasing axial length with myopia. We consider glaucoma suspect when one of the following is present: high IOP, optic disappearance, suspicious visual field, or increased corneal diameter or axial length with normal IOP in young children. The first thing is IOP. We consider it normal when it's less than 15 and pathological when it's more than 21. The first way to examine it is applanation tonometers, Goldman and Perkins, depending on the age. Tonopen and Iker are gaining popularity in the last years because they are easy to examine, but they used to overestimate the IOP, and we can obtain very variable measurements. So it's not the best way to examine the pressure. And we always have to take into account the possible artifacts that we can have, that is lead speculum, valsalma, that's in this case, general anesthesia, and pachymetry. When you examine pressure in the office, we try to avoid pressing over the lids with the fingers or the speculum. We try to pacify the child with feeding, sucking, or playing with them if they are toddlers, and read the tonometer between cries when the child is crying. But with a little bit of patience, we can obtain good measurements with awake children in the office, as you can see in these cases. General anesthesia, inhalatory agents used to lower the IOP. Midazolam and ketamine give more reliable lectures, but they have secondary effects. And the protocol we use is induction of the anesthesia with sevoflurane, turn off the gas when the child is asleep, and then measure the IOP when the eyes are centered. That this is just before awake. But the most important is use always the same method in order to be reliable with you. And the other artifact is the central corneal thickness. It's important to measure, but all the formula to correct the IOP, depending on the pachymetry, are not exact, especially if there is edema or scars in the cornea. Pachymetry also can be different in each examination depending on the degree of edema. So it's important to take into account, but not to quantify it. The second examination is the optic nerve examination, if it's possible, because thanks to the corneal clearness. We can examine with the ophthalmoscopy or retinography if possible to compare over the time. OCT is very useful to measure the disc area and to compare evolution, but there are not normal parameters for children in most devices, so it's not the same as useful as in adults. The third examination is visual field, but it's difficult to obtain a reliable computerized campimetry in children younger than 10 years, in my experience. We can obtain information by confrontation or new devices designed for children that they are based on preferential looking, but you cannot quantify the defect. And corneal examination is the most important examination in children. We have to examine the transparency by means of direct illumination or examining the red reflex. And you can observe if there are glaucomas or diffuse edema. Hab stria are tears in decimal membrane. They are pathognomonic of ocular hypertension in the first months of life. And we have to do the differential diagnosis with birth trauma in the absence of other signs of glaucoma. We have to measure very exactly the corneal diameter. These are the criterion of megalocornea in the horizontal corneal diameter, and taking in mind, very important, that any asymmetry of 1 millimeter or more is always pathological. Also, we have to measure the ocular enlargement. If the cornea is clear, we can do it with refraction under cycloplasia. And if not, we use the axial length, the measure of the axial length with biometry. Gonioscopy is not one of the requirements to confirm the diagnosis, but it's very important to confirm if there is agoniogenesia or disclose other forms of congenital glaucoma, and also to establish the chirurgical approach. We can do it by means of any of the goniolens we can have, and also with the RedCam or devices like this, we can obtain very good three-dimensional images of the angle, like in this case of rigor or in this case of primary congenital glaucoma. And finally, I'm going to establish the characteristics of the diagnosis depending on the age. In the glaucoma of neonatal onset, the hypertension is established before birth. So when the child is born, used to have a corneal edema very, very deep, or even a scarring of the cornea that can be irreversible. We have to perform the differential diagnosis with birth trauma, corneal dystrophy, metabolic or infection disease, and with Peter syndrome. And all the rest of the examination will help with this fact. An infantile onset glaucoma in younger than 2 years, the first thing is megalocornea. The second is the typical triad of epiphora, photophobia, blepharospasm. And sometimes this picture is the best picture we can obtain of these child. And corneal edema is least frequent and least severe, as you can see in this bottom picture. And finally, we have to perform a differential diagnosis of megalocornea with essential megalocornea, which is usually bilateral, symmetric, with normal IOP, without epiphora, photophobia, stria, disc cupping, and most important is no progressive. And the differential diagnosis with nasolacrimal duct obstruction, in which in this case we have discharge, more or less red eye, no megalocornea, no photophobia, no Hab stria, no disc cupping, no hypertension, and no photophobia. And finally, the late glaucoma that is diagnosed in older than 2 years of age. There are two forms: the late diagnosis of infantile glaucoma, with the child can arrive with an extreme ophthalmos, like in this case, that arrives from Africa in this situation, or late onset, in which case the goniogenesis is less severe. So we have subacute things that make difficult to diagnose this disease. And the only thing that you can find is a not severe megalocornea and progressive myopia. And that's all. Thank you very much. less severe. So we have subacute things that make difficult.
Sorry, but the video is not like
and the only thing that you can find is
Glaucoma Association as well as the
not severe
WSPOS for
megalocornea
inviting
and
me to
progressive
talk
myopia.
on signs,
And that's all. Thank you very
symptoms,
much.
So to begin with, I would like to thank the World Glaucoma Association as well as the WSPOS for inviting me to talk on signs, symptoms, diagnosis of juvenile onset open-angle glaucomas. So my talk is restricted to the juvenile onset open-angle glaucomas which are associated with high intraocular pressures. So 15 years ago, I was interested in this particular subtype of glaucomas, primarily because it was not so uncommon in our part of the world. We still see about 3 to 4 patients for every 100 new glaucoma patients that we see in our clinics. When we went back to the literature, we found that there was not much about juvenile open-angle glaucomas, and all that I could find was the description of few large families associated with juvenile open-angle glaucoma. The long-term management of this subgroup also is important because it's a socially productive age group. This person could be someone's father, someone's brother, someone's husband, or someone's son. So it's important in preventing blindness because it has not only important familial ramifications, but it also has a very important social impact if one can prevent visual morbidity in this particular age group. Finally, it's important to understand that the genetics of all glaucomas began with this subset of juvenile open-angle glaucomas, with the discovery of the myocilin gene. So what is known about juvenile onset open-angle glaucomas? Well, some consider it to be glaucomas happening less than 40 years of age and classify them as early onset POAGs. Others consider them to be developmental glaucomas happening between 5 to 35 years of age group. They're generally considered to be autosomal dominant with high intraocular pressures, leading to a deep, steep cupping and a generalized visual field loss. There's a very high incidence of myopia in these patients as well. So in our population, majority of them are generally males. The intraocular pressure may not be very high. In fact, most of our patients have intraocular pressure ranging between 20 to 30 millimeters of mercury, which means a lot of them can be managed on medical therapy alone. This also means that a lot of patients go undetected because there are hardly any symptoms. It's only when the intraocular pressure becomes very high that the patients may complain of colored halos, but till then, a lot of them will only present when one of their eyes is blind. So the intraocular pressure becomes high primarily because there is an angle dysgenesis, which if you do a gonioscopy can manifest in the form of a prominent iris processes, could be a high iris insertion, could be an angle which is absolutely featureless in some cases, so much so that that it almost gives the appearance of a ground glass membrane, which Barkan also described for primary congenital glaucomas. And this is due to compaction of the trabecular beams and prevent the outflow of the aqueous. So when we studied almost 300 of our patients, we realized almost 2/3 of these patients had some form of angle dysgenesis. But even if the angle is normal, you are likely to form some subtle anomalies in the angle which impede the outflow. And here you can see ASOCT images. And on the top image, you can see an ASOCT of the angle in high magnification, and you can see a Schlem's canal. The lower two images show you angle dysgenesis. This is a membrane at the angle, or you can see a high iris insertion in the form of the uveal tissue inserting anteriorly and preventing the aqueous outflow. Majority of these patients have a bilateral disease, but there could be a small group of patients may first present with a unilateral or an extremely asymmetric glaucoma, in which case it might be very difficult to distinguish from secondary glaucomas. There could be a lot of phenotypic variations in this disease. There could be a young person who might present with not so high intraocular pressures and yet may have a very advanced glaucomatous cupping. And at the other end of the spectrum, there might be a relatively older patient who presents with a very high intraocular pressure and a very severe visual field loss. So it's important to understand that not all patients less than 40 years of age with primary open-angle glaucoma have the same manifestations. There are a lot of variability in these patients. So these are some anterior segment iris photographs of patients of juvenile onset open-angle glaucoma. And while we were analyzing these patients, we realized that we could actually classify them based upon the iris morphology and the gonio-dysgenesis. And we used a cluster analysis to classify different types of juvenile open-angle glaucomas. So in this cluster analysis, we found that there was one group of patients who had a normal iris morphology and a normal appearing angle. And these were the patients who did not have very high intraocular pressure and they generally manifested later. There was another group of patients who had a featureless angle, and these were the ones that manifested earlier. There was one group of patients who had a high iris insertion, and these were associated with a higher intraocular pressure. And finally, there was this group where the iris crypts were extremely prominent, and this was invariably associated with a high iris insertion. This group generally presented with very high intraocular pressure. In fact, 70% of these patients had intraocular pressure above 50 millimeters of mercury. So we need to differentiate this particular disease from other glaucomas in this age group. One of them being pigment dispersion syndrome, another being steroid-induced glaucoma. We need to understand that congenital glaucomas are actually in a spectrum of juvenile open-angle glaucoma. So while congenital glaucoma is at one end of the spectrum, the primary adult onset open-angle glaucomas are at the other end of the spectrum. In some cases, you have to rule out a history of trauma. Some cases may manifest as a uveitic glaucoma and may be misdiagnosed as juvenile open-angle glaucoma unless a proper anterior segment examination is done. Primary angle closure glaucomas happening in the young may also be confused with a juvenile open-angle glaucoma. But if you do a gonioscopy, you can look at the convex configuration of the iris, and then you can kind of distinguish a primary angle closure glaucoma from a juvenile open-angle glaucoma. There will be subtle forms of Axenfeld rigors which may present in this age. Then there is a small group of patients which present with very large cups. And this is primarily because they were premature born, and a history has to be taken to rule out prematurity. Then finally, there is a small subgroup of normal tension glaucomas in the juvenile age group. So to summarize, we need a proper classification. We need to validate the classification that we have provided. We need to unravel other genes that could be associated and therefore provide some kind of genotype-phenotype correlation in this disease. Finally, an early diagnosis and management is important to prevent long-term visual morbidity. We have a survey ophthalmology review article on juvenile onset open-angle glaucoma that is recently published for those who are interested in this disease. Thank you.
Those were very nice presentations. Wonderful. And we have some questions from our audience that have come in. I'm going to start with questions regarding congenital glaucoma. So these would be to Alicia, that has to do with actually doing the exam under anesthesia. One question has to do with whether you recommend doing an exam under anesthesia if you are not someone who does childhood glaucoma surgery, or should you wait until you're prepared to treat?
I think it's difficult. I think it's better to use the same anesthetic moment for the surgery to complete the the examination. I mean, most of them, when you take a child to the theater, you know that you are going to operate on him, and you can complete the examination under the same general anesthesia, and you always can suspend the story if there is an error of the diagnosis. But you have to. It's usually you can have all the information. Can you hear me?
Thank you. Yes, thank you. One other question with regard to your exam under anesthesia. You reviewed quite nicely and in detail your type of anesthetic and the effect on intraocular pressure. The comment that I've received has to do with accuracy and type of measurement, whether you always use your Perkins and whether you do any sedated IOP measurements in a clinic.
I'm sorry, I don't understand the question.
Do you always use the Perkins device to measure pressure? Or do you ever use another device like Tonopen or eye care?
No, I always use the Perkins. I always use the Perkins. I mean, for example, when in my colleagues that are operating cataracts, they do the screening with eye care. But if they have a dot, then we measure with the Perkins, because eye care used to overestimate the IOP usually.
Dr. Gupta, is that your experience in exam under anesthesia? Do you also use a Perkins, or do you use another device?
Well, when there is a corneal opacity or the cornea is irregular, that's the time we would like to use either a Tonopen or we would use an eye care, because the Perkins might be not very useful in those particular cases.
And she reviewed quite nicely her anesthetics. Do you have a choice in what your anesthesiologist is using, or?
No. But what I generally do is I wait for some time after the anesthesia is given before I measure the intraocular pressure. You see, sometimes the intubation and even a laryngeal mask can cause a rise of intraocular pressure. So at one hand, there is the effect of anesthetists, which is going to bring down the intraocular pressure. And at the other hand, you have the effect of the intubation or the laryngeal intubation that is happening, which is going to raise the intraocular pressure. So it's always good to stabilize the child for some time, for a minute or so, before you actually measure the intraocular pressure. So that is one important thing. So what we do is we tend to look at the disc, or we try to measure the corneal diameter, and then go on to measure the intraocular pressure after some time.
Thank you. I believe this next question is for you also, regarding how do we suspect juvenile normal tension glaucoma, and how would you make that diagnosis?
Yeah, so it's not very common. Even among juvenile glaucomas, the normal tension group is really rare, and it's basically a diagnosis of exclusion. You need to exclude many conditions, especially autosomal dominant optic atrophies. And as I said, children born prematurely may come up with very large cupping, and they could also be misdiagnosed as juvenile normal tension glaucomas. So we only after exclusion of all other causes of high pressure glaucomas or burnt out glaucomas, steroid induced glaucoma that are burnt out, it's only after you excluded everything that you can come to a diagnosis of juvenile normal tension glaucoma.
Thank you. I want to go back to one other question here. Again, everybody has a different point of view here with regard to tonometers. And the question is, does anyone use pneumotonometry for a child that has corneal issues? Or do you go directly to Tonopen or rebound tonometry with eye care?
So I haven't used the pneumotonometer, and I primarily am using the eye care and the Tonopen.
Alicia, do you use any pneumotonometry?
No, never.
The next question has a little bit more to do with, again, still following patients and making a diagnosis, and what you feel the role of the axial length measurement is in pediatric cases. Alicia, why don't you start with us?
I used to measure the axial length or the refraction on the cycloplegia if it's possible, but there is not a measure. It's an orientative thing. It's not definite. I mean, it's not. There is not a measure that over this is a glaucoma and under this is not. So it's very important for progression, to evaluate progression, but not for establish the diagnosis in a given moment, in my experience. But I used to measure it, yes.
Dr. Gupta?
I think axial length is a very important parameter, and it is important for diagnosis as well as follow-up of these kids, because when you see that the intraocular pressure is lowered, there's also a possibility that the axial length might come back and might reduce, and also because it's going to be an important parameter for your refractions. So when you're doing refractions in these children, the axial length will give you some indication of what is going to happen. Is it becoming myopic? Is it becoming hypermetropic? So a lot of information you can gather with the axial length, and if you have a baseline measurement, it always helps in following up these children.
Okay, and the last two questions here have to do still with examination using different capabilities in your operating room, most likely. One is the role of using OCT, that is a anterior segment or high frequency OCT. Alicia?
I have it since very short time ago, so I'm not still introduce it in my routine, but I think it's going to be very useful for examination preoperatively, of course, but I'm not using it yet.
Dr. Gupta?
I think the anterior segment OCT, we've got an intraoperative ASOCT, and you know, when you're doing a goniotomy, it really helps to show exactly what kind of structures you're cutting. Not only that, as I showed you in some of the pictures, some of the images of the anterior segment OCT, when you see that the Schlemm's canal is not developed, then that's the point when you can think that probably this kind of congenital glaucoma is very severe and a goniotomy will not be a good enough option for this particular child. So visualizing the Schlemm's canal, I think, will become very important as the intraoperative OCTs become better and better, and if we are able to see that, we can really say that the Schlemm's canal is good, and therefore the angle surgery would be a better option compared to other surgeries.
And that is 10 minutes on our discussion here this morning. And I want to thank you for wonderful presentations and a very exciting discussion with a lot of information in there. We're going to move on now, and I believe Dr. Bob Weinreb is going to lead our next session. Thank you.
Great. Thanks very much, Alana, for moderating that excellent session. And the next session is really directed at therapy. We've heard about diagnosing the disease and recognizing childhood glaucoma. And with this, we're going to be talking about the medical and the surgical management of glaucoma. We have 4 speakers, including Dr. Eugenio Maul, who is the professor of the Department of Ophthalmology at Pontificia Universidad Católica de Chile. He's the honorary president of the Chilean Society of Glaucoma and has had longstanding interests in developmental glaucoma and the pharmacology of glaucoma. Our next speaker is Dr. Elena Bitrian, and she's associate professor of ophthalmology at Bascom Palmer Eye Institute and specializes in both adult and pediatric glaucoma, and is also the director of education for the Childhood Glaucoma Research Network. Third, we have Dr. John Grigg. He's coming to us from down under. He's the head of the discipline of clinical ophthalmology and eye health at the University of Sydney's Save Sight Institute. And he also has clinical responsibilities at the Sydney Eye Hospital, as well as the Sydney Children's Hospitals Network, which includes leading the clinical visual electrophysiology service. And last, we have Dr. Lauren Blieden, and she specializes also in medical and surgical management of adult and pediatric glaucoma. And she's at the Cullen Eye Institute of the University of Texas Health Science Center, where she's also the medical director of the Vail Ash Russell Clinical Research Unit. We'll have time for discussion. I'm going to turn the program over to Dr. Eugenio Maul.
Thank you for the invitation to participate in this webinar. Surgery is a mainstay of primary congenital glaucoma treatment and currently remains the standard of care. Angle surgery addresses the outflow pathway obstruction due to lack of cavitation and other abnormalities of the trabecular meshwork. Angle surgery is performed in 94% of primary glaucoma congenital cases. So, why care? Well, I show you here the results of an epidemiological study undertaken in the United Kingdom, which showed that IOP control with surgery is 60% with surgery only, and this increases to 94% with the addition of medical treatment. This is a clear indication of the role of medication in the management of primary congenital glaucoma when surgery is partially successful. Additional indications for medical treatment in these cases are temporizing prior to surgery. Many times, due to systemic reasons, patient must postpone the date of surgery, and this will prevent eventual complications like a prevention of corneal hydrops. And also, it will be helpful for clearing of corneal edema before surgery. On top of that, the treatment of juvenile open-angle glaucoma is generally medical treatment. In the photographs in the lower part of the slide, you may see a child with bilateral congenital glaucoma who has a corneal hydrops in his right eye, and this appeared during the waiting period. Fortunately, surgery was successful, as you see on the right photograph, where the cornea was cleared, except in the central part where you see an opacity related to a HAP striae. So this could be prevented with a stronger medical treatment. In secondary glaucoma, the situation is different. Medical treatment is first line. For example, 50% of aphakic glaucomas respond to medical treatment. Surgery is performed 4 weeks after diagnosis, as opposed to 1 week in patients with primary congenital glaucoma. During this period, the 4 weeks, patients are decided if they will be responsive to medical treatment or will need surgery. Now, if a surgery is needed, the surgical success rate in secondary glaucomas is only 28%. But this increases to 86% with additional medical treatment, reinforcing the concept that medical treatment is very important in the treatment of childhood glaucoma. Drugs, which to use? In children below 6 years of age, Timolol 0.1% in gel form or in solution of 0.25% twice a day will be helpful. In children older than 6 years of age, the solution of Timolol 0.5% twice a day is indicated. Dorzolamide 2% twice or 3 times a day is also very useful and a long time associated in the treatment of a childhood glaucoma. The fixed combination of Timolol and Dorzolamide, which appears convenient, may be used only after 6 years of age, and this due to the fact that Timolol in this fixed combination is in a 0.5% combination, indicated only after 6 years of age. Acetazolamide is also a long time associated in the treatment of primary congenital glaucoma. It is stronger than topical carbonic anhydrase inhibitor. It may be used at 10 to 20 milligrams per kilo per day, divided in 3 to 4 doses. And the problem with this is it may not be used for longer periods of time. Recently, latanoprost was incorporated into the armamentarium for the medical treatment of primary congenital glaucoma. Here I show you a study where the efficacy of latanoprost and timolol in pediatric glaucoma was compared in patients with primary congenital glaucoma and in patients with non-primary congenital glaucoma, which include the secondary glaucomas. As you see, the response rate to latanoprost in primary congenital glaucoma is 50%, and for timolol, 46%. And this increases to 72% for latanoprost in non-primary congenital glaucoma cases, and to 57% with timolol in non-primary congenital glaucoma. So both medications are very useful for the medical treatment of patients, children with glaucoma. Another advantage of this is that latanoprost may be used instead of timolol when there are contraindications for the use of timolol. Which drugs to avoid? Timolol is contraindicated in newborns. Brimonidine is contraindicated below 2 years of age, and it is not recommended between 3 and 6 years of age, so it may be used only after 6 years of age. Pilocarpine has been a long time used in primary congenital glaucoma. However, it is not very effective, so we don't recommend that for the medical treatment of primary congenital glaucoma. What about adverse events? It's important to advise parents and caretakers about adverse events because systemic symptoms from side effects are rarely expected to come from eye drops, innocent medication. So patients with cough, drowsiness, lack of appetite, nausea, dizziness, lethargy, headache, chest pain must be informed to the treating physician. Almost no systemic side effects occur with latanoprost, so there is a great advantage with this drug. It's effective and also a low percentage of side effects. About safety, package insert on topical medication warn that safety and efficacy has not been established in children. However, despite this fact, topical anti-glaucoma drugs are safe to use in children. Thank you very much.
Thank you very much, Dr. Weinreb, for the invitation to speak in today's webinar. I'm going to speak about the surgical approach in infants. It's important to divide the age of these patients. We know for primary congenital glaucoma, we divide the age of onset on 3 stages. Neonatal is when the disease shows in the first month of life. Infantile, when the symptoms occur 1 to 24 months. And late onset or late diagnosis, when the disease is diagnosed after 2 years of age. We know that neonatal glaucoma will have worse prognosis. So we have special challenges when treating glaucoma in infants. There's limited exposure at the time of surgery. This is a 9-week-old baby, and as you can see, her corneas are so large, there's barely no scleral exposure to perform an angle surgery ab externo. We also find anomalous Schlemm's canal, and often in these children, it will not be complete 360, and we won't be able to do a complete cannulation. And also we can find axial length shorter than in adults, and we'll have to do modifications when placing glaucoma drainage devices. So childhood glaucoma in infants, it's a special entity with several challenges. We do have a huge responsibility when bringing one of these children to the operating room. We put them under anesthesia and we need to do measurements of all their eyes and decide what's going to be the best surgical procedure for them. We basically have 3 boxes that fit the needs for surgical treatment. We have angle surgery procedures, which is the main treatment of choice. We also have filtering surgeries that includes deep sclerectomy, trabeculectomy, and glaucoma drainage devices. And lastly, we have cyclodestructive procedures. As we said, angle surgery is the procedure of choice, and it has better success outcomes in children from 3 to 2 years of age. We can do ab-interno procedures whenever there's a clear cornea, and this is a faster surgical technique and also spares the conjunctiva. Also, children tend to recover easier from these procedures since it's only a clear cornea incision. But when the cornea is cloudy, or when we have a significant anterior segment, this genesis, we benefit from doing ab-externo procedures. We can do goniotomy, which is a treatment of an incision of the trabecular meshwork with a needle. We can do a paracentesis, put myocol, viscoelastic, and use the needle to section side and side for 4 to 5 clock hours. However, some studies indicate that the treatment of 360 degrees is better. And on these children, not all the time will be possible, but we can attempt the treatment of a larger angle surface by using procedures such as Omni or GAT. As we said, with a needle, we can treat 4 to 5 clock hours. And here on the top right, we can see an Omni device, how we use this catheter to cannulate the Schlemm's canal 180 degrees. Then we withdraw this catheter as it deploys viscoelastic in the angle and dilates the collector channels. Subsequently, we'll just unroof the Schlemm's canal and perform a treatment of 180 degrees if possible, and then we can go back to the other side and complete at 360 degrees if the Schlemm's is permeable. And we can also perform a GAT procedure, and down here we can see we have incised the trabecular meshwork with an MBR blade, and we are advancing an illuminated catheter. As we advance the catheter, we do perform some viscodilation, again, of the Schlemm's and the collector channels. And then we can unroof and treat the 360 degrees. If the cornea is cloudy, we could go ab-externo, and we can do a trabeculotomy using a Harn's trabeculotom, which is this rigid probe, or we could try to go 360 by using a Prolin suture or by using an illuminated catheter. I do like using the illuminated catheter, especially on little infants, young infants, where the anatomy is not as regular. Here we can see an intraoperative photo of a trabeculotomy. We need to do a flap that it has to be deep enough that allows us to identify the Schlemm's a little easier. We do a cut down and spread tissue side to side until we see the reflux of aqueous from the Schlemm's. We can probe the Schlemm's canal, and we can actually treat it with a Harn's trabeculotom. And we can treat this 90 degrees and then the superior other 90 degrees. We can also try the Prolin in the Schlemm's canal and attempt to go 360, being aware that the anatomy can be misleading and we can end up in a collector channel. When we are done with a trabeculotomy, we have to close that incision very tightly to prevent a bleb, and also the scleral flap tightly with 10-0 nylon sutures. I like to close the conjunctiva with 10-0 Vicryl. We can also do our trabeculotomy with an illuminated catheter. And here we see a premature baby where we are performing a 360. The catheter is getting stuck here and usually happens like around 270. And what we do is we do a little more injection of viscoelastic and press on the scleral flap to help it advance. And then we just retrieve and treat 360 degrees of the canal. So the pearls for ab-externo trabeculotomy: don't make flaps too thin, sand out the Schlemm's with trabeculotoms, and if it doesn't work one direction, try the other way. You can also treat partially and do an additional cut down to retrieve the catheter. So when angle surgery doesn't work, we move on to filtering surgery. Trabeculotomy in infants is tricky, and if performed, it should be done with a Moorfield safer surgery system. Basically, they recommend to do fornix-based conjunctival flaps with a small radial scleral cuts. And the mitomycin is placed both under the sclera and under the conjunctiva. An AC maintainer is recommended while performing the surgery. And also often releasable sutures are placed that they will be released later on during subsequent exams under anesthesia. It has to be noted that trabeculectomies are less successful in children at less than 1 year old. So often, instead of trabeculectomies, we do drainage devices in infants. We can use bulb or non-bulb, and usually we're gonna place superotemporal if possible, if there's not too much scarring or thinning on the area. We recommend a limbus-based incision because it's gonna help with the recovery for the child. And we'll have some special considerations according to the different types of glaucomas. With adult surgery, what are the differences? We have, again, limited working space and a small palpebral fissure. The axial length needs to be taken into consideration. Some tubules will need to be trimmed if the infant is too young and the axial length is too short, and the Magenta-Friedman formula should be used for this. If we have thin sclera, we should avoid those areas to place scleral passes. And also, very important, plan for eye growth. An infant will grow, his eye will continue to grow, and we need to leave long tubes and place them peripherally. Also take into account that there's a possibility of occlusion on those children that have glaucoma following cataract surgery. In a nutshell, I recommend doing posterior conjunctival incisions and dissect anteriorly. Here you see a screenshot of how we do a placement, the pass with the needle through the sclera. So we don't point to the center, we just point a little bit more on the side. And then we close, after placing the tube, we will close the tenon with a running suture and the conjunctiva with another one. This will make it that the child has an easier recovery because they don't feel the stitches, and if they need contact lenses, they're able to wear them like very early on. Special considerations for tubules. In a Stusch-Weber syndrome, we need to avoid rapid decrease on pressure. And how do we do that? We can use Hilon intraoperatively or an AC maintainer. Often we do not do any fenestrations of the shunt, and we let it open up on the barbell devices. Sometimes we can think of placing intraluminal stents, and in extreme cases, high-risk cases, we will do a stage procedure. For aniridia patients, we do a limbal-based conjunctival incision to avoid the damage of stem cells. And we place the shunt, like you see in this photo, we place them peripheral, long enough because this is an infant, and avoid touching the lens. Following cataract surgery, if possible, we'll position the tube in sulcus or pars plana because it will protect the cornea and also will prevent tube erosions. Think always that these tubes will have a risk of occlusion and leave the tube long to allow direct visualization. We have many tube-related complications, especially when the shunts are placed at such young age. We can have pupillary irregularities, lenticular opacification, extrusion or migration of the shunt, and also tube cornea touch. And the last bucket of treatments, when angle surgery and filtering surgery have failed, we resort to cyclodestruction. In infants, we can perform cyclodestruction with a G-probe or with an MP3 probe micropulse cyclodestruction. We lower the settings and use less energy power, and we can also use endoscopic cyclophotocoagulation, like you see in this image, how we are shrinking the ciliary processes under direct visualization. In conclusion, when treating glaucoma in infants, preoperative exam and individualization of the treatment is key. Angle surgery is always the procedure of choice. Treat 360 degrees of the angle if possible. When doing filtering surgery, drainage devices or trabeculectomies, modifications are necessary, and the patient might need multiple surgeries. Thank you for your attention.
I'd like to thank the World Glaucoma Association and APOS for the opportunity to speak at this joint symposium on childhood glaucoma. I'm going to be talking on surgical approaches in young children. I have no disclosures. So to cover this area, I'm broken up into looking at children who are really 18 months to 8 years of age. And I'm going to cover 4 particular areas: those with primary congenital glaucoma, uveitic glaucoma, glaucoma associated with Sturge-Weber syndrome, and glaucoma after childhood cataract surgery. And it's useful to think about each of these categories. And when we come to look at primary congenital glaucoma in this young child group, they often have failed initial surgery or a late presentation, whereas the uveitic glaucoma, it's often primary surgery. Sturge-Weber syndrome may be primary or may have failed angle surgery from a younger presentation. And glaucoma after cataract surgery is usually primary surgery. So going through these, this is sort of some work that we did a few years ago, but the world literature shows multiple studies where angle surgery has a success rate of greater than 80%. So we're looking really at what happens to the 20% where the pressure is not well controlled. This is from our 120 eyes or so, and we looked at the age and the number of operations performed. And you can see on the left here in the under 2, this is when all the angle surgery occurs, and when it was multiple angle procedures, there's multiple of those. As a child ages, there's fewer surgeries, but they did seem to cluster in 2 particular points around the age of 3 and around the age of 6. And we wondered whether that might be related to the growth of the child. And then the other interesting point in our study was that after the age of 8, we only performed surgery on 7 individuals, or 7 additional operations. The significance of age 8 is that this is a time when it's thought that the ocular outflow system has reached adult maturity. So when we look at these patients, what's our approach? We now have the advantages that angle surgery can either have the standard 120 degrees or so angle surgery, or now with the 360-degree angle surgery with the different illuminated catheters. So our approach would be that if the child's under the age of 3 to 4 and they've only had 1 lot of angle surgery, we will repeat that. Now, if the pressure is not controlled, then we move on to the options of either a glaucoma drainage device or trabeculectomy. With angle surgery with 360 degrees, we really skip these other angle procedures. And so then we're in this group of either using glaucoma drainage device or trabeculectomy. And we find that to get the best outcome, under the age of 4, we would tend to prefer a glaucoma drainage device just because of compliance and the ability to modify the wound healing afterwards. Whereas over the age of 4, many children are able to tolerate manipulation of the wound healing, or they tolerate repeated examinations under anaesthetic. Then finally, if these things don't work, then we have found that either a repeat trabeculectomy or adding a trabeculectomy to a glaucoma drainage device provides additional assistance in controlling intraocular pressure. So that's our overview and flowchart for uncontrolled primary congenital glaucoma in that age range of 18 months to 8 years of age. Uveitic glaucoma in children is very challenging. And I think we've really become much better at managing the inflammation and managing this in multidisciplinary team meetings. So we really need to be quite aggressive in this management, moving from topical steroids and steroid agents to steroid-sparing agents such as methotrexate. And if there's really no improvement to the biologic agents such as Humira or infliximab, and we need to move through those steps at a faster rate to minimize damage. So this is a flow chart that's taken from the book that we were all part of with the World Glaucoma Consensus Series. And we emphasize the importance of immunosuppression, but uncontrolled uveitic glaucoma, if the angle's open, then there's 2 pathways. We can have angle surgery, which is occurring in a few centers, but the majority of centers would prefer to move to an aqueous shunt, aqueous drainage device, and that's certainly our center would prefer to do that. If that's failing, I think a step that we would add to the algorithm now is to really reevaluate immunosuppression. And our experience is that even if there's no inflammatory cells, there may be flare, and this may be significant enough that we really need to reconsider optimizing the immunosuppression. And we found some good success in rescuing glaucoma drainage device procedures by optimizing their immunosuppression. And this is done in consultation with our multidisciplinary team with pediatric rheumatology. The other group that I wanted to talk about was Sturge-Weber syndrome. And we've chosen this one because it's one that provides another of our main challenges in managing these children. And we have a large number of these children who come through our clinic. So many of these children, they present early with glaucoma or raised intraocular pressure. they'll be suitable for angle surgery. We would caution as there's not enough evidence for 360-degree angle surgery at this time. Once they have had this, then the second peak of raised intraocular pressure that's difficult to control occurs really in the 2 to 5 year age group or up to around 8 years of age group. And so in the young children, we find a glaucoma drainage device is the optimum treatment for this group, mainly because these children often have significant other medical problems, either neurological problems or seizures, or they have associated behavioral issues such as ADHD, that are parts of their Sturge-Weber syndrome, and managing that in glaucoma surgery in these young age groups, then the glaucoma drainage device helps there. Once they're over the age of 5, in this cohort, we find that primary trabeculectomy is actually probably more efficacious than the glaucoma drainage devices, and we showed that in a study recently published in the Journal of Glaucoma. If that fails, then we'd look at a glaucoma drainage device then. Cyclid diet is an option, but we reserve that sort of more for end stage, and we have to be cautious in these patients who, depending on how much of conjunctival vascular malformation they have. So that's our outline for Sturge-Weber syndrome. The final group, and one of our largest groups, is a management of glaucoma following cataract surgery. And this is another flow chart that's been adapted from the World Glaucoma Consensus Series. And here, initial therapy is often medical. Then really the decision tree is that if there's raised pressure, is pupil block present? Because this will require specific surgical correction to relieve the pupil block with removal of the Sommering ring residual cataract and a surgical peripheral iridectomy. If it's open angle, then we look at what the optical correction is. If they're wearing a contact lens, then trabeculectomy has a poor outcome, so we would move straight to a glaucoma drainage device. If they're not a contact lens wearer, then depending on their age, then trabeculectomy plus antifibrotic agents would be an option. And then if this is not working, then going back to the glaucoma drainage device. So we find that probably in the majority of these children, then a glaucoma drainage device would be the main procedure that we would use, mainly because of the optical correction that's been carried out with contact lenses. So to conclude, we've talked a lot about glaucoma drainage devices as a significant option in this group. And I thought it'd be useful just to remind us of how this works, and particularly revisit some of the work from Tony Maltino, who looked at wound healing in these. And basically, he highlighted that the final thickness and permeability of the capsule depended on the relative intensity of opposing aqueous-induced fibroproliferative forces and fibrodegenerative processes. And so that work led to the concept that if we had no aqueous flow for the first 4 weeks, we developed a thinner capsule, and hence the possibility of lower long-term pressure. Also, that highlighted that the standard tube, there's no measurable resistance to outflow, and we're looking at physiological perfusion for flow rates of 2 to 4 microliters per minute. And to remind us that it is a bidirectional flow, so what goes up can come back down, but also inflammatory mediators can flow both ways. Also, the importance of the explant size correlates with the amount of drainage capacity. And I think that's important when we're looking at different drainage sites, sized devices and the newer ones coming out. And this impacts on the potential lowering of intraocular pressure. We also highlight that capsule thickness correlates with capsule hydraulic conductivity, which comes back to our first point. The thinner the capsule, the lower the pressure. And aqueous moves through the capsule by simple passive diffusion. So if you have thicker capsules or inflamed capsules, then this will impact on how that glaucoma drainage device works. So with this overview, I conclude there. I'd like to thank our unit at the Children's Hospital Westmead, with Dr. Karakonji and Dr. Zagora, who've helped with the collection of the data. So thank you, and we look forward to any discussion and questions.
Hello, I'm Lauren Blieden from the Cullen Eye Institute at Baylor College of Medicine, and I'll be discussing surgical approaches, adults with prior surgery. I don't have any financial disclosures related to this talk, although there is some information I received from Glaucos from their recent presentation of a sponsored study done at ASCRS. Let's be clear. The definition of failure in this setting is the inability to prevent progression of disease using tolerated medical options, and this talk assumes that angle surgery has already been performed. The primary TVT study, just to review, showed that trabeculectomy did better at 3 years with lower baseline initial pressures, is more likely to get you off medications, but trabeculectomy carries a slight risk of more serious complications compared to a tube shunt. So primary trabeculectomy will get you lower with less meds, but safety on tubes is better. In the US, in a child that's already received angle surgery, the go-to procedure if the anatomy is amenable is a tube shunt. So most likely we will be talking about what to do after a tube shunt, but I do know that some of you practice in countries where trabeculectomy may be the case. There's no real evidence on secondary surgeries for Zen, gel stent, or PreserFlow, a few case reports at this time. That's still to be hashed out in our collective experience. So you've got somebody who's had a first filtering procedure. Let's talk about the rates of failure. So for the best case scenario with trabeculectomy, you can expect those trabs to have a survival rate of about 60% at year 6. For the less optimal conditions like neovascular glaucoma, which is pro-inflammatory and generally not look to be an ideal situation for trabeculectomy, the success rates at 1 month look really good at 71%, but by a year, only 29% of them are still working. Again, in this population, you're most likely looking at patients that have already had a tube shunt. Failure rates of the first tube in adult populations range from 90 to 50%, varying on the definition, the device type, the definition of failure, the study design, the length of follow-up. Most retrospective studies show higher rates of failure around 3 to 6 years with upwards of 30 to 50%. And this is consistent with data that was recently presented at the inaugural North American Pediatric Glaucoma Society, as well as APOS, from papers done by Brenda Bonsack's group and Alan Beck's group, showing survival rates of both Bearvelt and Ahmed FP7 data in children. So here are your options. You can revise, you can do a second trab, you can do a laser either to the trabecular meshwork or the ciliary body, a second tube, or a trabecular meshwork-based procedure. The data for revision is actually quite good if you have someone with a failed trab and amenable tissue sitting in front of you. Del Noche et al. Reported statistically significant results with mitomycin versus needling alone. So this is blood needling using mitomycin as an adjuvant. 101 patients with 30 months follow-up, so quite a significant follow-up period in that study. And Khan et al. Found similar results with 71% of mitomycin needled bloods requiring no further medicine or intervention at year 1, and 61% of them still working at year 2. So you can buy quite a bit of time by trying to revive that initial trabeculectomy. Tube revision or replacement is a little bit more muddy in the literature. You can try flushing the tube to expand or fracture the capsule. There's no evidence for this that I could find. You could resect the capsule, with some reports showing success of upwards of 50%, depending on the definition and the follow-up. There was only one study comparing resection of the capsule versus the second tube. The second tube did better, but the corneas of the patients did not. And you can also remove and replace the tube with a different type of tube. A very small series of 9 patients showed modest success rates, actually in all of the cases, in all of the 9 patients, with only 2 of them failing after about 5 to 8 years of good follow-up. So we can revise our trabeculectomies. We're not sure about revising the tube shunts. Second trabeculectomy. Rates of failure of second trabs are actually worse than the rates of failure of needling with mitomycin, with success rates at year 3 being reported as up to 32 to 41%. Without mitomycin, you may as well not try. The failure rates are about 50% with a mean time to failure of about 4.5 months. What about trabeculectomy after tube shunt? There are certainly issues with conjunctiva. Here, there's no published data, although I'm sure people have tried. There are case reports and a few small case series of using Zen or PreserFlow after a tube shunt fails. I think this would be a better option if you wanted a smaller footprint on the conjunctiva than doing a full-on trabeculectomy. So second trab after trab, I think if that's what you do and you do it well in your population, it's a perfectly reasonable option, and the literature supports that, although shows lower rates of success than just needling. And I'm not sure there's really a role after a tube shunt. What about laser? Well, CPC, we have several retrospective studies that will, after tube shunt, that we'll study in a little bit more detail in just a minute. Endocyclophotocoagulation, or ECP, there's one study after tube shunt with 25 patients that had modest success rates at about a year, 88%, with complications that would be expected with laser and inflammation, such as decreased vision, CME, and corneal graft failure. Micropulse is gaining popularity. It's still early to tell. There have been some posters presented. I couldn't find a good paper on micropulse after tube or trab. And then SLT, I think you could extrapolate the argon laser trabeculoplasty data from the AEGIS trials for trabs, but there's no papers or looking at SLT or ALT after tube shunts. I think if the angle is amenable and this is part of your practice, you could certainly try. So trabeculectomy, I think you could try. A TM-based laser. Ciliary body laser, I think, is a good option after both trab or tube failure. What about a second tube? The TBT study looked at trab versus tube after incisional procedures. There were a lot of patients that only had cataract surgery, which qualified as their incisional procedure, but there was also a good portion of this population that had trabeculectomy first and looked at a second trab versus a tube. The 5-year longevity from this study actually was better for the tube shunts, but if the trab survived, which we saw the rates of second trabs are survivals relatively lower, the outcomes were similar. So if you can get that second trab to work, it'll work, but a tube may be more consistent. So we move on to a second implant. They definitely work, but they come with a cost, especially with rates of corneal edema. This may increase the risk of issue with the first implant, and it may also increase the risk of endophthalmitis versus other options that are non-incisional, such as CPC. There's not much data on whether you use the same device or different, and location is very important. We would typically recommend using the quadrant opposite to the first device. So tube after trab and tube after tube is a very valid choice, and the literature would support you on that. The 5-year survival data from the 2 biggest retrospective studies looking at transscleral cyclophotocoagulation or a second glaucoma implant after the initial tube shunt fails show that both are fairly good options. The CPC group seemed to require more additional intervention in the Wang study, but in the Schaefer study, the tube shunts did. And it mainly had to do with how they defined the time points to that secondary intervention and whether they, how they treated the patients with the initial settings on the laser. The most important takeaway, though, is that once somebody has a tube that's not working, they tend not to do well. And you can see here the visual outcomes from the Schaefer paper that showed 60% of the patients in the tube group lost 2 or more lines of Snellen acuity, and 20% of the CPC group did. So the CPC group fared a little bit better, but a lot of patients lost vision in this study in general. To summarize the data of a CPC versus a secondary implant, the success rates are fairly comparable, with success rates reported upwards of 88 and 86%. The main complication in the literature out of the CPC group was reported to be hypotony, and the additional main complication for an additional implant was corneal edema. Capsule excision had very low rates of very low numbers in the papers that are published. The success rates appear to be good, I guess, depending on your technique and your own populations, but there were lower rates of corneal decompensation. Importantly, in many of the papers I reviewed for this talk, regardless of the intervention, there were decreases in visual acuity. The ASSIST trial was a prospective trial that was designed to look at what to do when the first tube shunt fails. It was transscleral cyclophotocoagulation versus a second tube shunt. It ended early due to difficulty in recruitment numbers, especially as the pandemic began, but we did present preliminary data at the last American Academy of Ophthalmology meeting, and basically showed that both groups were equivalent in terms of IOP results. So if you like to do CPC after a tube, you're just as likely to bring the IOP down to the same level as your colleague who may like to do tube shunts after tubes. And we also learned that these eyes just tend to do badly. So I think you should need to have a very frank conversation with your patients about the need for additional procedures and medication. The paper is pending publication. What about TM-based procedures, or the new stuff, the new old stuff? A lot of this patient population will have already had trabecular meshwork-based procedures, goniotomies or trabeculotomies. So you really need to evaluate the tissue to see if it would be amenable to receiving another procedure. There's one study on angle-naive patients with trabectome that showed survival rates of 84% at 12 months with no major events, which is nice. No endophthalmitis, no NLP, vision, etc. So very low risk for complication. The data received from Glaucos that was presented at ASCRS recently through company-sponsored research looked at iStent Infinite after tube shunt specifically and saw a nice change from baseline, with over 50% of the subjects having at least a 30% change from baseline with iStent Infinite after initial tube shunt. So I think both of these small papers and studies indicate that perhaps you could revive the angle if the tissue is amenable. So I don't really know. I think, especially in a population that's already had angle-based surgery, but I think here's a summary of the options available to us and the literature behind them and how they would be supported by the evidence. And I thank you for your time this morning, and I hope you enjoy the rest of the conference.
Well, great. Thank you. Thank you to each of our speakers. And we do have time for discussion, and we have so many questions. As you can imagine, the complicated subject like this. Let me just start off with medical therapy. And Eugenio Maul made the great point that medical therapy is really not chronic in these patients, but it's really done in advance of surgery. Eugenio, a couple questions focused on the use of timolol. And you mentioned the use of timolol 0.5% twice daily. And I'm wondering, why not just use it once daily? We're all concerned about potential systemic effects, in children and certainly in adults. We're using it once daily. We know that timolol is not particularly effective at nighttime. Why not just use it in the morning?
Well, we use, I recommend to use timolol 0.5% in children over than 6 years of age. And children below 6 years of age, I recommend only 0.25 solution or the gel in the 0.1% solution. Of course, you may try first once a day and see which are the results. Fortunately, in cases where you are in a doubt about indicating a timolol, we have the option now of using latanoprost. But those would be my recommendations. And that's also the reason, because I do not recommend fixed combinations in children below 6 years of age, because the higher concentration of timolol gives options, more opportunities for side effects.
Great. So some of the other speakers, anybody using timolol just once a day, and anybody teaching parents about punctal occlusion, blocking the nasolacrimal duct to prevent systemic absorption. Elena?
Yes, so we do give timolol 0.25% early on, but we give it once a day. Initially, exactly. Sometimes if we have to escalate the therapy, we will do twice a day, but usually it's only once a day. We do teach the parents to do punctal occlusion, especially at a younger age, to minimize the absorption of that. That's correct, yes.
Great. And Lauren, are you doing the same?
Yes, I do the same. So I'll use 0.25% timolol once a day. If the child is very tenuous, I don't use it. I'll use dorzolamide instead. Often it's just a temporizing measure till we can get the child to surgery. So hopefully very short term.
Right. And what's your first line therapy? Would you use timolol or would you use latanoprost?
If I'm using a medication first line, it's because I'm trying to get the child temporized to the operating room. So latanoprost would not have a long enough, a quick enough onset of action. So I'll use 0.25% timolol or topical brinzolamide or dorzolamide to temporize the child till we get to the operating room. Once I've done surgery, typically I'll go to latanoprost first.
Great. John, how about you?
Yeah, we often use betaxolol actually to start with, in these being a selective beta blocker, and that'll be my first line in these certainly under the 12-month age group children, and certainly in that period of temporizing to surgery. In fact, we also use pilocarpine in that time as well. We try to do the punctal occlusion, but in children it can be quite challenging.
quite challenging. And betaxolol is a cardioselective, so less effects on the pulmonary system, and it's a twice daily drug, unlike timolol, which often is used once daily.
Yeah, so I think that sometimes twice daily actually gives better coverage for the time, particularly when the parents, it's new for them to putting eye drops in children, and particularly if they're challenging, then at least you've got a second chance of getting the drug in with less systemic side effects, I think, than timolol.
Right. Elena, you talked about angle procedures, and certainly it's revolutionizing, adult surgery. And we're still, I would say, uncertain about many of these procedures with childhood glaucoma. Do you have a preference for an angle procedure, and how do you decide? Certainly if you have a clear cornea, you have a number of options. How do you decide?
So it's all about the exam, do the best educated choice. I do prefer a Vinterno if the cornea is clear enough, and I do prefer a procedure that is going to treat me 360 if possible. So I do like gut procedures a lot. If I have any concerns that the SLEMS is not continuous, I might choose an Omni procedure because I can easily treat on one side as many clock hours as I can, and then go the inferior side and treat others. But always, yes, try to treat as much as we could. If the cornea is cloudy, obviously I have external, and I do like the eye tract catheter with the illuminated tip. We can try to go around 360 and viscodilate the canal as well.
Right. Now, let me bring up something that, I wondered about as I was listening to Lauren. And this is a fundamental question of glaucoma, and most of you take care of adults. She presented a lot of data on, studies that have been done, and it's wonderful that we're beginning to acquire data in adults for surgical outcomes, which we never had before. However, we really don't have those data for children yet. And I'm wondering what you think about using the results from adults. Do they apply to children? Are the same types of results expected, the things that we see with TVT and all these other studies? Lauren presented a lot of data, but those studies are in large part in adults. John, you want to comment on that?
I think that's a really interesting point. And I think we do extrapolate from adults to children because that's the only data we have. We are building up retrospective series for our angle surgery and for really the case series. I think the other thing that children is a growing eye, and so that brings another factor into the whole process. And I think we're still really a little unsure about what role inflammation has to play. I mean, it's sort of 15 years ago, we had a lot of talk and understanding about wound healing for our filtering surgeries, trabeculectomies, and the role in the glaucoma drainage devices. And that's partly why I presented some of the work that Tony Maltino, since I was certainly influenced by his work. We probably, most of us probably don't use the Maltino cocktail with our filtering surgery, but we have seen more now when we come to look at patients with uveitis. Now we've got access to much better control of their inflammation, such as the biologics, that we get much better outcome if we can really control the inflammation in a long-term basis. And I've certainly seen that we can rescue tubes down the track if we can control the inflammation better. So I think to answer your question, there are specific pediatric factors we need to take into account. The growing eye, inflammation may have a greater role in this age group. And so that needs to be taken into account when we compare with the adult results, but we do have to extrapolate.
Yeah. Eugenio, how about you? You're an experienced adult surgeon as well. Do you extrapolate your techniques and the results that have been acquired in adult surgeries to children?
Well, we use that as a guidance, and we face still, the trial and error approach and see what will happen. Like for instance, in primary congenital glaucoma, when when two angle surgeries fail, the next step, as Lauren said, the two options are good. Tube after chop or chop after tube are two good options. However, if you take into account the age, my preference is to do first a tube in children below 2 years of age and trabeculectomy first in children over 2 years of age. But still,
Elena, I saw you nodding your head, Elena. Do you want to comment on that as well? You know, extrapolation of results, you know, to children that have been acquired in adults.
So we have to take them with a grain of salt, obviously. I do agree. With younger kids, I do not like filtering procedures like trabeculectomy because it's a risk, like mitomycin on such a young child, the needs for repeated exams under anesthesia to release sutures, and also because the increases scarring. So I think it's I think we have way more benefits with a drainage device. I agree with like angle. Secondly, treat and repeat the angle a second time in most of the cases, and then move to a glaucoma device on younger children.
Great. Lauren, any concerns about using mitomycin C, 5-FU in children? Elena, we just heard from Elena about concerns with mitomycin. How about you? Do you have concerns?
Yes, I do. I think, and I think your point is very valid. You have to look at these evidence from the adult world with a grain of salt, and always look at your table 1 to see if the population you're treating is similar to what the study was looking at. Mitomycin in children, we don't really know the effects of systemic absorption or how it affects the tissue for other surgeries down the line. Another point about the selection of tube or trab in a young child is also dependent upon where you live. I live in a place where a lot of kids swim in oceans and fresh water and lakes and streams, and they're very active. So the idea of a mitomycin, trabeculectomy for the infection risk alone usually pushes me away from that in a younger, even active adult, whether or not it's a child that I'm treating.
Yeah, it's so challenging, the surgery in young children. We have these Schlemm's canal-based procedures. Elena mentioned Omni procedure, catheterizing Schlemm's canal. And then, of course, many of these kids don't even have a Schlemm's canal. And it points out, you know, the important role of imaging and obtaining better methods of imaging. And that might guide, you know, where we go with our surgery. So, you know, another question that's come up is the role of cyclophotocoagulation. You know, first of all, is there a role for cyclophotocoagulation in children? And secondly, if you are going to do cyclophotocoagulation, are we going to be doing it the conventional way, or are we going to be using micropulse? John, you want to take that one?
Yeah, thank you. I think there is a role. I think there's two roles. There is a role in children where angle surgery's failed and there's concerns about the next step, and it can be used as a temporizing procedure, I think. And so rather than performing the full sort of treatment protocol you might use in an adult, then sort of 15 or 20 shots in 3 quadrants will help get that child through some period of time. And this is maybe the reason you're delaying a tube implant because of other social circumstances and other things like that. Then I think it then has another role in basically those where they've failed glaucoma tube implants that I think that Lauren and Elena both had discussed before. I think that the cyclodiode, when it's applied in the full treatment in those older children, even then it doesn't last as long. I think there's a regenerative capacity of these children, and that sort of will limit its life. And so I wouldn't repeat more than twice that procedure. I find that the micropulse can be temporizing, but it's a very short period of time, so I really don't use that anymore, just from my personal experience.
Right. Elena, any comments on that? And also comment on, you know, the amount of energy. I mean, sclera, is it the same as adults? You know, are you going to alter the amount of energy you're delivering? And what's your experience with micropulse?
I do like micropoles. I do reserve cyclodestructive procedures for the very last resource. So to me, it's like I wouldn't do it as a first before trying a drainage device or angle. I do like, I've done micropoles. I think I feel comfortable because it's like a less energy. The thing is also, I would remember, like we see a lot of kids that have had cyclodestructive procedures, and later in life they need a fusion, and that's a recipe a lot of times for disaster, because those a lot of those eyes end up being physical. And we see people that in other countries they have a CPC, they only have access to this resource, and then when they come here, we see bad outcomes of that. So I just want to mention that and remember.
What kind of endpoint do you use? How do you decide what type of parameters to use with your micropulse? Duty cycle, energy, and power.
So the same, I do the same for the micropulse. I do exactly the same as an adult.
Right. And is there any way to know at the time of treatment that you're achieving the intended effect?
There is no way there is no way to know. I've done that after I have a child with like the 2 tuitions, but at the time of treatment, I just do my treatment around, I do 3 quadrants and I leave 1 spare.
Right. Eugenio, are you doing CPC, micropulse, and what's your approach?
I use it very little. I agree with John. It helps for a while, and I do it in very poor cases. And I use the micropulse with the same setting as in adults. But I don't expect very much from that.
And Lauren, you had a major role in the Rob Feldman's ASSIST study. Mm-hmm. You have a lot of experience with cyclophotocoagulation. Any differences in your application with children?
Yes. So there are a couple of differences. I really don't use micropulse because I have so much more experience with traditional diode cyclophotocoagulation using the G probe. I start with particularly low settings in children because their sclera is thinner. So you're more likely to get that kind of pop at a much lower power level. For example, I had a child last week who we went down to 700 milliwatts and before we didn't hear a pop. So you want to be very careful. The other thing I've noticed in children is that their limbal architecture is very obscured, especially in cases like Peters anomaly or Axenfeld's. And transillumination is often helpful to be able to use a surgical marker to outline where the ciliary body is. That gives you a much more predictable place to target your laser, and I think you get a much more predictable result. But typically much lower settings, long durations, 4 seconds, and I go slow. I'd rather come back and repeat a little more than overtreat.
Great. I was surprised in your lecture that you even mentioned laser trabeculoplasty. Do you want to comment on that? Laser trabeculoplasty in a child or an infant?
So my charge for the lecture was adults with prior surgery, and I mentioned it out of completeness with the caveat that the angles we're talking about are likely not normal angles, but assuming you have, for example, a late onset juvenile open angle glaucoma patient with a relatively normal angle, you could extrapolate the data from the AEGIS trial, which was quite robust, looking at ALT and trabeculectomy, although I think most of us would not approach it that way.
Great. In the remaining minute and a half, couple very quick questions. Anybody using aproclonidine at all in children?
So it can be before surgery. It will prevent bleeding, like before a drop before angle surgery. So intraoperatively, yes, it has an application.
Right. Sturge-Weber. This one is probably a book. Somebody's asking, how do you prevent effusions with Sturge-Weber? Elena, you want to? Go ahead, John.
Yeah, I think the risk of effusion depends on the size of the choroidal vascular malformation. And if it's very large, well, then it's got a high risk. So you then use the anterior chamber maintainer as discussed. But if it's smaller, then the risks are much lower. So I think it's your fundal examination will help guide
to be able to predict the risk.
Agree.
Great.
And always be super cautious. And ligate tubes don't fenestrate, even do a stage 2 shunt on these cases.
I typically, if I'm very concerned, will also do a scleral cut down at the same time of both, of actually opening the tube. So I'll do a staged procedure or with a rip cord where I go in and make a scleral cut down, fill the anterior chamber with OVD, and then open the tube and watch them very closely before we wake them up.
Well, clearly surgery in infants and children are some of the most challenging things that we face in glaucoma. And it's great to hear from some experts on the subject. I'm going to turn it over now to the final session. And thank you, everyone, for joining us.
Hello. Thank you very much. I appreciate the invitation to be here today. I thank WSPOS and WGA for inviting me to be here. And this section is very interesting because we will invite experienced specialists to speak about a challenging theme that is how to determine success in these kids after treatment. This is very challenging. We know that in adults, we have already well determined which are the parameters we should use to find success criteria, but in children, sometimes it's very challenging. So I will introduce the next speakers and panelists. Dr. Nischal has already been introduced. I will introduce Dr. Tanuj Dada. Dr. Tanuj is a professor of ophthalmology and head of glaucoma service at the RP Center for Ophthalmic Sciences, All India Institute of Medical Science, New Delhi. He currently serves on the board of directors of the Asia Pacific Glaucoma Society as secretary of the International Society of Glaucoma Surgery, and he's a member of the Education and Consensus Committees of the World Glaucoma Association. Dr. Vera Essuman, that will be joining as a panelist, is an associated professor of ophthalmology and head of the Ophthalmology Unity, Department of Surgery, University of Ghana Medical School, College of Health Science, University of Ghana. She's also the head of Pediatric Ophthalmology and Strabismus Unit of the Lions International Eye Center at Kolebu Teaching Hospital, Accra, Ghana. She's the first pediatric ophthalmologist to be trained and pioneer in the pediatric ophthalmology specialty in Ghana since 2004. Dr. Dominique Bremont-Gignac, also a panelist, is a professor of ophthalmology and head of the ophthalmology department with a pediatric subspecialty at Université Necker-Enfants Malade Hospital in Paris, 5 René Descartes University in Paris. She's also the head of Paris and Orthoptic Department and the chief of Clarop Research Clinical Center, as well as of TARA, Rare Ocular Disease Reference Center. Now we are going to call Dr. Nischal to, actually it will be the same theme of the two next presentations, viewed by two different, very experienced specialists. The theme of the presentation will be what is success, IOP, or quality of life. Please, Dr. Ken, let's see the video.
It's my great honor and pleasure to talk in this joint WGA-WSPOS webinar about what exactly is success when we talk about pediatric glaucoma. Is it intraocular pressure, quality of life, or is it vision? These are my disclosures. None of them are pertinent to today's talk. So I think it's important, before I talk about intraocular pressure and vision, that I talk about quality of life. I say that because, you know, as a clinical ophthalmologist, I don't really think about the quality of life tools that are present, but I know that they're used to ascertain social, emotional, and participation aspects of daily living. They're used for adults a lot. A lot of adult-focused studies will have quality of life tools used in them for many years, and there's an abundance of choice for adult studies, but not so for children-focused studies. There are a few, however. The Children's Visual Function Questionnaire is a quality of life scale, but it uses proxy opinion, not that of the child. There are vision-specific pediatric scales measuring visual functioning, and they are available, one from LV Prasad and one from the Cardiff Visual Ability group. But the one that seems to be used more recently is the Impact of Vision Impairment for Children, IVIC, and it's a vision-specific quality of life scale to assess self-reported vision-specific quality of life in school-age children. Now, I do not have the time to go into the ins and outs of this, but I would, if you're interested, there's a great paper about a brief guide to the selection of quality of life instruments, and the IVIC I'm going to go into in a little bit more detail. It's a 24-item vision-related quality of life instrument developed from thematic analysis of focus group discussion of children with visual impairment and without visual impairment. It has excellent psychometric properties. It's been validated in children with and without visual impairment, as I said, and it's scored from 0 to 96, with the lower scores representing a better visual-related quality of life. So this is a paper that I would recommend reading, vision-related quality of life in children with glaucoma. Now, I always thought, honestly, that the drops would be a real issue, right? But what they found in 43 subjects who were able to complete the IVIC, they found scores ranging from 0 to 56. The scatter plot shows each patient, and obviously the lower the score, the better. And this is what they found. The score was not related to sex, age, race, bilaterality or unilaterality of disease, the number of eye surgeries, the number of glaucoma medications prescribed, or how frequently they were prescribed. Absolutely not. The only thing that they found was that in a linear regression analysis, sharper visual acuity in the better seeing eye was related to a better vision-related quality of life, better vision. So let's look at that and look at it practically. This is a clinical audit, and we do a lot of clinical outcome audits in my group at Pittsburgh, carried out by two fellows, ex-fellows who are now attendings at Pittsburgh, Dr. Eldeeb and Dr. Hayasat. And they basically looked at outcome of filtration surgery in children. And the primary outcomes were success as defined by intraocular pressure control, but then it was postoperative best corrected visual acuity, postoperative amount of cylinder, postoperative amount of anisometropia, and the mean number of anti-glaucoma eye drops at last follow-up. The methodology was of the combined trabeculectomy, trabeculotomy was as previously published by my group in 2008, and it involved the use of mitomycin and releasable sutures. So there were 18 patients, 26 eyes. This is the demographic split. And you can see that the follow-up, the median follow-up was over 50 months. The diagnosis of the presentation, the majority were primary congenital glaucoma. So let's get this right. This study that I'm talking to you about is about primary congenital glaucoma outcomes. There was one eye with juvenile glaucoma and one associated with anterior segment dysgenesis. Luckily, that none of the operated eyes had severe or vision-threatening complications, and none of the eyes developed avascular cystic plebs. The success we found was about 75% using 2 or less drops, and 55% were off-wall drops at last follow-up. 88% had IOP success if it didn't matter how many drops they were using. If you compare that to other studies, it's pretty good. But here's the thing: the other studies often didn't mention vision. There were about 2 other studies that had previously mentioned vision. And so when we looked at our findings, we found at last follow-up, the mean distance visual acuity was 0.85. Remember, these were majority were primary congenital glaucoma. And if you look, 13 out of 8 eyes, Harbstrie were involving the visual axis. So the conclusion of the study, and I'm not going to talk about the other conclusions about how combined trabeculectomy trabeculotomy with mitomycin C seems to work, that the surgical technique was safe. I want to talk about the fact that despite a good intraocular pressure control, postoperative visual acuity was poor. And this was because of astigmatism, anisometropia, amblyopia, and Harb's-Tree. Remember, the majority of these eyes had congenital glaucoma. So the Harb's-Tree, when they occur in the visual axis, they really cause aberrations, visual aberrations. So we need to start thinking about, once we've controlled the pressure, what do we do for these children who are in the amblyopic age to try and get that visual axis clear? And that's work that will be published shortly from my group. And I think it's worth us thinking about the quality of life, sharp image, and how a sharp image is what gives you a higher score for vision-related quality of life. Look, on that note, I'd like to invite everybody to come to the subspecialty day for WSPOS on Friday, the 16th of September in Milan. It's the day before ESCRS. And I want to thank everybody for listening to me today.
Hello, everyone. I'll be covering what is a successful outcome for childhood glaucoma, and especially concentrating on congenital glaucoma. I have no financial disclosures. So you have to understand what is the normal IOP in children and what is our target IOP for congenital glaucoma. If you see the distribution of intraocular pressure in a normal pediatric population, you will find that the intraocular pressure is much lower as compared to that of adults. If you see from this study that we did in our center, the intraocular pressure approximately increases by millimeters of mercury for every year up to 10 years. So if you take primary congenital glaucoma less than 2 years, the mean intraocular pressure in that age group for normal children is 8 millimeters of mercury with a range of 4 to 11 millimeters of mercury. So it's important to understand when you're setting a target IOP for a child less than 2 years, the normal intraocular pressure varies between 8 to 10 millimeters of mercury. Therefore, in this study, we tried to evaluate the target intraocular pressure in eyes with primary congenital glaucoma. And what we found was that if you achieved the intraocular pressure of less than equal to 50 millimeters of mercury, these were the eyes that did not progress and neither had an increase in the degree of refractive error, as compared to eyes which had an IOP of more than 15 millimeters of mercury that showed progression of myopia and also increase in the cup disc ratio. So although several studies are reporting a target IOP of less than 21 for eyes with congenital glaucoma, this is not appropriate, and we should use a low cutoff of less than equal to 50 millimeters of mercury as a success criteria for eyes with congenital glaucoma, and this may go up to 80 millimeters of mercury when the child is more than 2 years of age. In addition to the intraocular pressure, if you find that there is a change in corneal diameter or an increase in cup disc ratio, or a patient shows an increase in axial length beyond what is normal for the age, or progressive myopia, especially in one eye, these are surrogate markers that the intraocular pressure, even though it may be controlled, is high for that eye, and you need to further lower the intraocular pressure for that patient. Coming to the visual acuity criteria, what is success? A visual acuity in the better eye of at least 20/40 in a child who has achieved 3 years of age is classified as a successful visual outcome. In patients who have visual acuity of less than 6/18, those are classified as moderate or severe visual impairments. And of course, less than 3/60 is classified as blindness. It's important to always objectively evaluate the visual acuity in childhood glaucoma. For toddlers, you can use the Teller acuity chart, and for children between 2 to 5 years, use the Cardiff acuity chart. So you objectively evaluate both the eyes for what is the level of visual acuity. And when the child goes beyond 5 years, you can also evaluate the higher visual functions such as stereopsis to see how the child is progressing. And this is an important thing which may be useful when he goes into adult life and does fine work. If you see this study on the long-term outcomes of primary congenital glaucoma with more than 33 years of mean follow-up, the patients are classified into 3 broad categories. 1/3 of patients have stable glaucoma with no visual impairments. 30% of patients undergo glaucoma progression with sight-threatening complications. And it's important to understand that this requires a lifetime follow-up because many patients have good visual acuity in childhood, but when they reach adulthood, at any time during the adulthood, the visual acuity can fall. And the third category is poor visual acuity as a result of ocular comorbidity that may be in the form of amblyopia, corneal edema, or a retinal detachment. If you see the long-term visual outcomes in children with congenital glaucoma, you will find that the main cause of visual impairment is amblyopia. It was 64% in this study, and that is mainly related to the anisometropia and the corneal opacification. In this trial from China, in 95 eyes, again, the most common cause of decreased visual acuity other than the glaucomatous optic neuropathy was again amblyopia, 64% of patients. So occlusion therapy for amblyopia is very important when you're dealing with pediatric glaucoma. It's important to understand the difference between visual impairment in adults and children, because if you have a loss of visual acuity in children, that has major lifelong consequences in the form of a global developmental delay. The child may have impairment of motor function, language, emotional, social, and cognitive development. He may have lower levels of educational achievement, and most importantly, for a personal freedom, he may have inability to get a driving license if his visual acuity falls below 20/40. Finally, what about the quality of life of patients and their caregivers? When the child becomes more than 8 years of age, the quality of life in the form of patient-reported outcome measures can be evaluated by simple tests such as the Kid Screen Questionnaire. And you will find that many of the children have a reduced health-related quality of life despite a successful surgery in terms of intraocular pressure outcome. And when the child is above 10 years and you can perform a visual field, there is a direct correlation between the mean deviation loss and the quality of life that can impact the functional vision and the quality of life of children and can be evaluated by visual fields when the child is more than 10 years. And finally, what about the caregiver burden? The main burden falls on the mother of these children with congenital glaucoma. And caregivers suffer from a greater psychological disturbances as well as physical disorders as compared to non-caregivers. And in fact, a primary caregiving role mediated by caregiver burden is an independent risk factor for increased mortality rate. And what is more relevant is that the caregiver stress, especially in mothers, has been noted to lead to behavioral disturbances in children. So this is something we must address. And this was one of the first studies that we did at our center to evaluate the caregiver burden in parents of primary congenital glaucoma children. And we found that the caregivers, especially the mothers, had significant emotional and psychological burden, and 1/3 of them were suffering from depression. There are now various simple questionnaires available that can be used to evaluate the caregiver burden, such as the caregiver congenital glaucoma quality of life burden, which is a 20-item questionnaire. And furthermore, if you find that the caregiver has anxiety, depression, or a high level of burden, this is a study showing a meta-analysis of meditative interventions for caregivers. And they found that with these interventions, you can have improvement in depression, anxiety, stress, and self-efficacy. To summarize, what is a successful outcome for a child with congenital glaucoma? A low target IOP, less than 15, maintained lifelong, an asymptomatic child with no photophobia, no asymmetric increase in myopia leading to anisometropia, a visual acuity of at least 20/40 in the better eye, which makes him eligible for a driving license, no retinal or corneal complications, an optimal health-related quality of life of the child so that he can actively participate in academic sports, have a unique family life with an adequate social performance, and the alleviation of the caregiver burden or the parents of the child with congenital glaucoma. And this can be only achieved with a comprehensive team with eye care physicians, the glaucoma surgeons, the pediatricians, the rehabilitation specialists, the school teachers, coupled with the psychiatrists and nursing staff. And with this, we can achieve success. And for us, that may be to know that even one life has breathed easier because we have lived, that is to have succeeded. Thank you very much for your kind attention.
Well, after these two great presentations, I think we will have the pleasure to open the discussion. Actually, we'll invite the panelists to be here with us now. And the first question I will address to Dr. Nischal, asking him how does he manage the post-operative in order to detect, control, and at what time does he begin to treat amblyopia?
So, I mean, yes, can you hear me?
Yeah.
Okay,
Perfectly.
so I think that's a great question. I mean, as soon as you get, in congenital glaucoma, as soon as you get corneal clarity, that's your first sign that things are going the right way. You get reversal of the optic disc. I now use rebound tonometry a lot. If I've done a goniotomy, it's almost immediate. You see the clearing the following day. Often the corneas are not that cloudy anyway because you've done the goniotomy. If the cornea is cloudy, I tend to do a combined procedure. Anil Mandel's work in southern India was very, very convincing to me, and I've been doing that ever since I visited him probably 24 years ago. You treat glaucoma, you treat amblyopia as soon as you're out of the post-operative period, around 4 weeks, once you're off the post-operative drops, and you've got to be aggressive about it. You've got to get the glasses on if they need glasses, and you've got to start the patching. And there's a lot of counseling about patching to parents, and how important it is. And of course, we're talking about children who are well under the age of 8.
Perfect. Thank you, Ken. I will ask for Vera, how does she does in the post-operative, how is the routine in Ghana to deal with these children after the surgeries? Do you do biometry with which frequency, and how do you manage it?
So in Ghana, as part of our post-op management, we ensure that, especially the first day post-op, you may not be able to gain a lot, but the intraocular pressure and assessment of the cornea details, especially the congenital ones, is important. We ensure that if the cornea, and we expect that the cornea should be clearing progressively within the first month.
Perfect.
We want that to help us in terms of noting whether there's progression or not. So as we go along, the visual acuity appropriate for the age is done. And as soon as we detect that there is amblyopia, we come in to treat. We prefer even though it is available, please, can you hear me?
Now, yes. I think the internet is a little bit bad.
Oh, so sorry then. So as I was saying, we prefer the occlusion method for amblyopia. So we keep up with the refraction, and when the cornea is clear enough, we put them into glasses if it's needed with amblyopia treatment. But we assess the visual acuity using appropriate methods. I think what our challenge really is that our children are presenting late. And so the cornea, the state of the cornea tends to cause a lot of problems, like Ken and the others presented. So very significant heart striae, sometimes cornea fibrosis, central cornea fibrosis. So you achieve IOP targets, pressures, normal pressures, but the vision is not that good. And it is even worse with the unilateral because of amblyopia. And so maybe if I'm to speak my mind on it, I would say that it is not just enough, achieving good IOP success. One will have to aim at getting good vision so that the children can see and participate in other activities of life.
Yes, thank you, Vera. That's true. We have the same problem in developing world, that the arriving of the children sometimes is late, and that's a great problem for us to deal with the corneal sequelae. I would like to ask Dr. Bremond-Gignac, which are also the other parameters it's used to control? Do you use corneal diameter, and in which frequency do you do biometry in France? How do you deal with that?
That's a very good question, and thank you very much for asking. Of course, there is not only IOP, and I think axial length is really very, very important. Of course, also the length of the cornea. And so it depends on the age, of course, of the child. So if you have really in a congenital glaucoma, the axial length is very important, and so we can have the control every 3 months or even longer if they are older. And we try to do it if we can have general examination because we think we are going to make another surgery. Of course, we do it during that, or if not, we can control that with an ultrasound by touching. And it's always very difficult, I think, in consultation to get the axial, the length of the cornea. But when you combine all of these, I think that's a good thing to have a good evaluation of the progressing or not progressing glaucoma. The other point, which is to my thinking important, is also the refraction. Because if you see the myopia just growing, so that's also a problem because you think that the axial length is growing at the same time. So all these parameters can be good to be checked regularly.
And what I would ask you also is, how do you differentiate the myopia related to IOP, uncontrolled IOP, from the myopia that is epidemic nowadays, especially at 4 and to 6 years old? How do you differentiate? Because even sometimes they have some clouding that could also contribute to the eye enlargement. So it's very challenging.
That's very challenging, of course. Of course, it's very challenging. It depends also on the age. I think when you have a child who is 6 years old, of course, that's sometimes difficult to know if it's the glaucoma just growing, evolving, or if it's just a myopia like this. In this case, when they are older, I think the optic actual lens is nice also to get this way. But in this case, I think in 6 years old, we can have some visual field, some OCT or the optic nerve. And so they can give you some evaluation also to think that it is not glaucoma evoluting, but it's just myopia. But even if it's just myopia, we must be careful. And maybe we can try to get some stopping system for the myopia and try to get that in addition to the other treatments.
Yes, I think that's very challenging because sometimes optic nerve also changes, isn't it?
Yeah, that's true also.
Even OCT can change when the child is getting more myopic, so it can be very challenging.
Yeah.
Very interesting. Let's see here. For Professor Dada, could you tell us a little bit more about the psychological consequence of primary congenital glaucoma? Because these children, they have very specific behaviors, and also they have a specific way to, I think there is a similarity in this group, in this specific situation, in this context of psychological consequences. Could you speak a little bit about it?
So I think the psychological impact of this disease is widely neglected, and we have also not been giving enough emphasis on it, but it is a very vital part of management. So whenever you are handling pediatric glaucoma, you must have access to a department of psychiatry or a psychologist. So when the children come in very young, say neonates or less than 2 years, you cannot evaluate the quality of life of the child, but you can do that for the caregiver. And you have these very young mothers in their early 20s and often with more than one child. And they have this huge stress of managing the family, managing the child. And often the society puts the blame on the mother that it is because of them that they have produced these diseased children. So I think the residents and the ophthalmologists managing these people need to talk to the mother and find out about the economic and the social status and what sort of problem she's having, and then refer this patient to appropriate psychological counseling facility on a regular basis. And you'll be amazed to see that how much was the psychological problem and how much they benefited. And that indirectly impacts the quality of life of the child. Now, once the child grows up and goes to school and he has an impaired visual acuity, so that impedes the cognitive function of the child. So you have special groups which can do rehabilitation of these children, both optical as well as the psychological rehabilitation. So they have to be referred to appropriate specialists for counseling, evaluation, and then appropriate treatment so that they come at par with their fellow students in the class. And many of them, of course, even the best you try, they end up with blindness and they go to blind schools. So they also suffer from great psychological problems. So I think all departments handling pediatric glaucoma must refer both the caregivers and the children for appropriate psychological counseling. And there are very nice therapies available and which can benefit, which you should be aware of. And that we won't be able to manage that as ophthalmologists, but it is our duty to refer and be aware of these problems in these children. Thank you.
Perfect. Ken, would you like to tell us how is your structure in regard to this psychological approach of these kids? Do you have a psychologist in your service that can help with this?
No, we don't have one.
We don't hear you.
And department. So if we feel it's necessary, then we do refer patients. I must admit, I don't think we've been as aware of the caregiver's psychological state as we have been of the child's. And Tanuj's talk today has made me think about some things that we need to introduce in our service to make sure that they get the help. Funnily enough, we have a lot of help for all the children and the families for whom I do corneal transplants, but we haven't done that for the glaucoma, congenital glaucoma children. So I think that's a thing that we need to do.
That was great. Thank you for all. It's very interesting theme, I guess. Thank you, everybody. I will call Dr. Fabian Lerner to finish our session. And it was a pleasure to be here with you in this Saturday. Thank you very much, everybody.
Thank you.
Thank you.
Thank you very much. What a webinar. Was fantastic. The 4 sessions were just fantastic. So I'm gonna just share my screen. And of course, it is time to say thank you. Thank you for this great webinar. We had more than 2,500 attendees through the different platforms. I think this is a record for pediatric glaucoma. I'm not sure if there are more than 2,500 individuals taking care of pediatric glaucoma in the world. So thank you to the World Society of Pediatric Ophthalmology and Strabismus. It's been a pleasure to do this webinar with the 2 societies. Thank you to the program organizing committee, the program director, the moderators, the speakers, and the panelists. Thank you to WGA Executive Office, particularly Irene and Mariah. Thank you very much for all your hard work. To NDOT officers and the IT team, thank you very, very much. And of course, the audience. I encourage you to open the camera in your phones and take a picture of this QR code that will take you to the survey that usually help us a lot to plan ahead for the upcoming webinars. So we take into consideration your opinion. And please plan and mark your calendar for the next World Glaucoma Congress in June 28th, 2023, in beautiful Rome in Italy, where we be getting together on the 10th anniversary of World Glaucoma Congresses. This Congress is co-hosted by the 2 glaucoma societies in Italy. This is a Congress you do not want to miss. And thank you very much for joining this 8th webinar of the WGA Global Webinars. And I'm gonna ask all the speakers to turn on the cameras so we can take a group picture. Okay. Okay, thank you very much and enjoy the rest of the weekend, everybody.
Thank you.
Bye-bye.
Thank you.
Thank you.